Shadi or Shai. Stevie Isaac, welcome. I can't find music and play. Salmon Dan, hola, how are you doing? Ansel Davidson. I'm gonna find some music I'm playing in the meantime. Let's see if Alpha. Find the music and play. Oh, can't use it on this. Welcome, Rayon. Who's that? Akinyan. All right, Destiny's Margaret. How are you guys doing? I know it's just a pass through. I pass through too. Oh Lord. Akinyan Julie. Am I saying it correctly? Hi Jan. I don't know if you're here. Welcome, welcome, welcome to my live. Trying to find a little music so I can play in the background so my live not look that boring. You know? iTunes. Oh, I was listening to this young lady. Kelani. Yeah. Eddie Campbell, hola, Luxury 64. You already know. How are you doing? Yes, I said let me just jump on to the live and just chit chat for a little bit. Braids by Luna. Chrissy, Wagwan, how are you doing? Simo, Shireen, Roy, Joyce Morrison. Hola, welcome, welcome, welcome. Who is joined? Who is on the live now? I see 2 persons on the live. Who is on the live with me? Flower, Tony. Hi, Andrew King. Okay. I wanted to just kind of talk a little bit about night shift, day shift, which one you guys prefer, pros and cons, things like that. Just kind of chit chat for a little bit. I know it's 8 o'clock. Oh, let me send out the live. How do I do this thing again? Sim, how are you? Okay. I think probably a lot of persons are. Yeah. So, you know, with nursing, we do a lot of shifts, different shifts, mid shifts, day shift, night shift. But some persons have their favorite shift. and we just want to talk a little bit more about that. Just kind of here want to headspace the why you guys do certain shifts, you know. I used to do and if you're joining me for the first time, I'm Stacy and Stacy. I'm originally from Jamaica, but I work here in the US now. And yeah, my background is in emergency room nursing. I do house call as a nurse practitioner. So I'm on the road a lot of times driving up and down like a race car driver. Not a race car driver, but I do a lot of driving. Angela, what's up? How are you doing? I do a lot of driving throughout the day. Today I had, how many patients I saw today? It wasn't so bad. I think I saw about, oh, I have it in front of me. 6 patients, and then I did 1 televisit afterwards for this patient that I saw about a week ago. But otherwise, it's fine. I love the shift that I'm doing now because I have the flexibility. Just come from work. Okay, cool. Yes, I have the flexibility now versus when I was working in the hospital. The hospital, I never really have that much of a flexibility because of the 12-hour shifts. I used to do, back in Jamaica, it was more of a mixture of shifts. And then when I got here to the States, yeah, I was on night shift. I had a contract for nights and started out, I never really liked it, but eventually.
It's not even 9 o'clock yet.
You don't go to your bed at 9 o'clock. You go to your bed now. Turn off the TV for me, please, and go brush your teeth. Yeah. Zarian? Yeah, so when I started out on night shift here in 2016, and I spent a couple of years well on night shift. I never thought I would have stayed on night shift, but it did work out in my favor, so just kind of hung out on it for a little bit. But I did pick up like day shifts and the mid shifts. I did a lot of mid shifts. Day shifts wasn't my, you know, my thing because it was hard for me to wake up early in the morning for work here in the US. Back in Jamaica, I don't have a problem working night shift, but day shift. But here in the States, I don't know. I think probably because of the time, you know, the difference. It just messes you up. It's harder to get up here in the States for a 7 o'clock shift. And even if I get up, I normally get up at 5 o'clock. Even if I do get up at 5 o'clock, it's still hard for me to stay, not really to stay awake, but that energy, that vibe that you would normally go in for work with, I don't have it when I get into work here. And it's not like my sleep pattern or, you know, the time that I wake up has changed significantly, no. So I did love my night shift, and some days on days, it was okay. But how many persons? I see 4 persons here. How many persons are nurses here in the States or even in Jamaica? Where are you joining in from? Oh, everybody gone. Who is on the live with me now? I see 2 persons. Who is on the live with me? Just say hi. Just say hi so I can know that I have company. I know that Angela was here earlier. I don't know if Angela left because she just, you know, popping in from work. But let's just talk a little bit about the day shift in the meantime, and then we can ask some questions and answer them and hear, you know, which shift you prefer and why. But with the day shift, or yeah, with the day shift, with the pros for the day shift, you know that resources are always available. So you can find basically everything on day shift. And it was the same thing like in Jamaica. Like not everything, but what we have access to. And when I got here to the state, it was even, you know, just the same. You have a lot of doctors, you have your CNAs, the support staff, they're always available on day shift. I think probably because day shift, you know, they're anticipating a lot of patients turn out, so you always have good stock. You know, the stocking on the floors are a little bit better on day shift. You learn more on days too, definitely. You learn a lot more on days because, as I say, you have more like doctors, your CNAs. Yeah, so and then depending on the hospital that you're working as well, you learn a lot more. Communication. Do you find communication a little bit easier on day shift? Sometimes, depending on what's going on. Yeah. Communication is a little bit easier sometimes on day shift. I think probably because there's just so much. But then again, I never really like day shift that much because sometimes when I have too much work or too much staff, sometimes the work is not being done. That's how I feel. If you have too much staff, you realize that the work is not being done, or people just sit down and watch them one another. So that was the other thing I never really like about day shift. Whenever the shift is like too packed with staff, then it's always a bit of a problem. Certain things don't get done on day shift. But day shift is good for persons who have kids. So if you want a very, if you have kids and you have certain schedule that you have to work out with your kids and, other family members, then day shift usually works out a little bit better. Because even in Jamaica, a lot of persons who were like, single parent and they just have their kids that they have to drop off, pick up, the day shift always work out for them. When it's time to go home, it's the same thing. And then with your sleep, your circadian rhythm is not like affected on day shift that much. It's not. So you tend to have, better sleep patterns on day shift. One Love, hi, how are you doing? I am doing good. Thank you for asking. Yeah, so your sleep cycle is a little bit better on day shift, and that is one thing that I did like about it. It's faster pace. Yes, it's a little bit faster on day shift because, as I say, you have so much, almost every department is open. You have all the support staff you need. So you're not supposed to be slow. You're not supposed to be slow on day shift. Everything is like, getting done. And then with the managers on the shift as well. Yeah, they kind of rush you to get certain things done according to, especially the time-sensitive things. So you find out that it's a much faster pace for day shift than night. And as we said before, the learning opportunities are better. So a little bit better because, as I say, because of the fast pace, you have to be careful with that, especially if you're a new graduate. Sometimes you might not get a chance to learn as how you'd want to on a day shift, just because sometimes depending on the speed, sometimes, persons forget you. So you have to just be a little bit inquisitive or hungry to learn on day shift for you to actually keep up with them. Georgie Lawrence, hi, how are you guys? On day shift, though, some of the cons is that the constant interruptions, because what? You have everybody on the shift, you have every family member coming in, and they're not coming in at a specific time. They come right around the clock, and so you tend to be doing something, and family members want an update. You have a procedure going on, doctor probably needs something. So there's always a constant, interruptions on that shift. Management is always everywhere looking out, making sure that you're doing, crossing your T's and dotting your I's. I like management, but not so much. Not so much. Because it forces you, it's like it forces you to, when they're on the floor, it forces you to work harder. And then you have some people who are going to try to impress and all of them stuff, and we can't keep up with it. So I prefer to be on night shift all the way. I prefer night shift. On day shift, you tend to have a lot of admissions, though. You tend to have a lot of admissions on day shift and discharges on day shift. Because, some facilities don't discharge at certain time. But on day shift, you're getting all of the admissions. So if you want to improve in that area, then that is the shift for you. And we talk about the family members who are always there, because everybody's up during the daytime. People want to sleep in the night. So nobody's going to be hanging out after 5-6 o'clock. So you realize that the day shift is always swarmed with patients' relatives. And then we talk about, it's harder to sit down on day shift and chart. Sometimes you see persons hiding because they just need to catch up on their notes. Because if they sit at the nurse's station, is either the constant calling with the call bell, or the family members always coming over there. So it's hard for you to get your charts done on day shift than before. And then the constant traffic, or the traffic when you're getting into work and after work, that is a problem as well. Because when I was working at this facility before, my drive time would be probably like a 25 minutes. But I have to leave out like 1 hour before, because the traffic was always just so congested in the morning, because everybody is wanting to get to work And it's the same thing, everybody leaving work in the evening, so you always have this congestion. So I kind of just like, night shift here in America. It just works out so much better. A night shift works out for persons who are like in school. A lot of persons who are in school tend to prefer a night shift because it's a little bit of a slower pace, and you get to catch up on certain things. All right, welcome, welcome, welcome. Okay, nobody never say anything in the chat. All right, let me just continue. Punam Yada Dava. Dottie, how are you? Bestie 123, how are you doing? And then with night shift, which is what a lot of persons tend to like, we love the shift differentials that come with night shift. Oh, day shift don't carry the shift differentials. Yeah, so more work, but they don't carry shift differentials. Night shift does have shift differentials, which is nice. So a lot of persons tend to love night shift. And then you feel a little bit more independent when you're working on night shift versus day shift. So that is one thing that you'll find that is nice on night shift, the workflow. Some people think it's a little bit easier to chart on night shift, and that's because we don't have so much of a traffic with, patients, relatives, the back and forth. And plus sometimes on the night shift as well, the patients don't call that well enough because they want to sleep. So them lie down in them bed and them sleep, and unless they need a blanket or a pillow or something, or really and truly pain, and they're having a lot of pain, then they'll probably ring that call bell. So it's not so noisy on night shift in comparison to day shift. And the teamwork, I find that the teamwork is so much better on night shift. I don't know, wherever I work, it's always the same thing. The teamwork, the folks on night shift just seem to be a little bit more mature, regardless of how busy the department is. The walls could be tumbling down. Night shift will, they'll keep and sometimes the shift is short staff. The shift is short staff, but they just seem to get things done. And it's not like, difficult after whenever you settle the crisis. It's not difficult for persons to kind of get back into their workflow. So that little teamwork I love on night shift. It's more team nursing. When I go on day shift, I feel like everybody is just doing their own thing. Nobody really know which patient who needs something down that side, or they're not helping. Yeah, they don't really do much of a team nursing on day shift, I find. So I never really like that. Unless management is around on night shift, you do have your managers, your supervisors for night shift, but they're not like, walking through the department every second. Yeah, we don't have that. And it's usually quieter on night shift, which is nice. The sleep schedule, though, a lot of persons struggle with that because, your body is accustomed to days, right? Your body is accustomed to that. So your circadian rhythm definitely is affected on night shift. Because sometimes I realize when I was doing nights, and even now, it's hard for me to still sleep in the daytime. I can't sleep in the day, so I still have to be doing a lot of things in the nighttime because that's what I've been doing for the last couple of years. Working, I'm always up in the night working. So you have a lot of persons who will complain or tell you that when it comes on to getting anything done, like with their personal life, it's always affected on night shift. If they're working night shift, it's always affected just because of that, the time that they would normally be working and when they would be sleeping. It's harder to balance relationship and social life on night shift because you're always working. And not only that, you tend to be missing out on certain things during the daytime. You miss out a lot of things during the daytime for as a nurse or a healthcare provider that is working night shift, because during the daytime every activity is going on. Your kids in school, they're having their activities, you're missing that. So it affects that a lot. The resources are usually a little bit fewer because by the time day shift finish, all of the resources, most of the time them don't restock, and so you find out that there's not much resources for you to use on night shift. And then when it comes on to getting food, So you have to either perform before or order a little bit earlier, because some places are not like, say, 24 hours. So it's difficult for you to get some food on night shift. So that's one of the other problem. And then the exhaustion, even on your off days, you're always feeling exhausted. Some days when I was working nights, I would find myself sleeping for the whole time. So if I'm off for probably like 3 days, I'm probably just sleeping. And I feel as though I am not getting the rest that I need. So even on your off days, you're still feeling exhausted. But when you work day shift, you realize that you feel a little bit better in terms of, you know, your overall, like you're not feeling so stressed out just because your body is accustomed to sleeping during the night. So that's just that. But I want to know what shift. I only have 2 persons here. What shift do you currently work? What shift do you currently work? You can just go ahead and type it in the chat. What shift do you currently work? No. Akusia, Tressa, welcome. Asha, welcome. Governor, Miss Joy. Oh, Miss Joy Brooks. Yeah, what shift you guys work currently? As I said, for me, you know, I am very flexible with my shift. I work in the daytime, and I work between, like, say, 9:30 to 1 o'clock, and that's it. And it's just because I work in the outpatient setting. Most persons will be working probably like a 8 to 5, 9 to 5, thereabout, and you get the nights off, which is nice. But if you're working in the hospital, a lot of persons will be working the mix shifts, or day shift, night shift, that kind of vibe. Which shift is harder mentally? I would say probably the day shift. I find day shift a little bit. I think probably because it's just like so crowded and you're having to deal with so many persons. Mentally, yeah, it's hard to keep up. It's hard to keep up because you have the patients that you're dealing with and the family members. There's so much emotions. You're already tired from the day before. So to me, that is the hardest shift to deal with. It's always the hardest shift to deal with. All the ambulances, or a lot of ambulances coming in at that time. Your codes coming in. Because especially the nursing home, the assisted living, for some strange reason, that is a time when 5 o'clock in the morning is a time when everybody decided to go and check the glucose. And, you know, who almost dead, who dead, whose glucose is very low, and they're coming in. So it starts off with a big bang in the mornings, a lot of times for day shift, and ends with a big bang. So mentally, I feel as though day shift is one of the hardest shift. Physically, which one is the hardest? I think day shift as well. Even though on night shift, it is sometimes not 100% staff. I feel as though just the teamwork, the bond, and the mature, you know, the staff that are working on the floor, them always just seem mature and know what they're doing on night shift. Not saying anything with day shift, but I'm just talking about my experience. So even though, yes, you would think that it's going to be harder on night shift, I feel as though day shift is a little bit harder physically because there's just so much work to do. The admissions, the discharge, you know, a lot of ambulances coming in because everybody, especially when it comes on to some of the homeless patients, you have to deal with them on day shift. You have to deal with a lot of them on day shift. So I feel as though day shift physically is harder than night shift. Angelo, how are you doing? Welcome. What shift do you work now, Angelo? Would you ever switch shifts? Would you ever switch your shift right now? I don't know what shift you're working. Would you switch your shift right now, Angelo? Okay, good, nice. So whatever shift you're working right now, do you love your shift as a nurse, or, you know, in general? Do you love your shift that you're working? Some days I would think that I would want to go back into the emergency room because I'm missing the hands-on. I miss the emergency room, the business of the emergency room, but the shift is a problem. I can't find a job that is going to tell me come in at 9 o'clock and leave at 5 o'clock. That is a problem. So I will not switch my shift right now just because I like the flexibility I have with it. You were day, not night. Okay. So I wouldn't switch right now just because of the flexibility I have with it, and that's just it. What's the craziest thing you've seen on night shift as a nurse? On farm work. Okay, no problem. Toporis. I'm a CNA new to night shift med surgeon. I'm starting to really enjoy compared to days. Yeah, a lot of persons tend to like night shift than day shift. And if you're an international nurse and you get a contract for the night shift, I would say go ahead and take it, because you will realize that you have a lot of time to catch up on certain things, learn a few things, the policies, the protocols for the facility, and you get your own little system going in terms of how you know, with patient care. So it's a little bit easier for you to start off on night shift than on day shift, because day shift is very chaotic. It's very chaotic. And if you're not a strong person, I feel as though dealing with the transition into the States here, you know, adjusting to the, you know, the culture and everything, the culture in the department, if you're not that strong, it can be hard for you. It will be harder for you because you're just dealing with so much with transitioning as well. Well, what's the craziest thing you've seen on night shift? The craziest thing I've seen on night shift for me was, I did talk about this story with a lady who was, well, they called to say that there was a patient coming in and the patient has maggots. The last time I had a maggot, you know, a really bad maggot infested wound was when I was in Jamaica. And we don't really have ambulances that are taking patients. You know, you call the ambulance and say, hey, I'm going to the hospital. No, this patient came in a van back. And the patient, at the time, we have some, you know, the little plastic bags that you get in Walmart. We have some black ones in Jamaica. We call them black scandal bag. So at the time, there was this patient. I was working triage, but the triage that I was working was inside the emergency room. And there was this patient that came in. But when they brought the patient in, the patient had her leg in one of those Walmart bag or black scandal bag. That's how they wrap up the lady's leg. And when I was there sitting, like they were wheeling her down and everybody started clearing the department. I'm there waiting because she's coming to triage. Elderly lady. It turned out that when she got closer, I wanted to run as well, but you know, I had to keep my composure. And while I was there, the only thing I could hear was zzz in the bag. I mean, I wonder what that zzz, like when I tell you the entire department, if we needed beds at that time, like we could have gotten all the beds clear out. You could know who was sick from who was not sick. But this lady had some really huge maggots and flies in that bag. And I tell you, when I tell you that I never see it at the time, you know, but you could just hear the maggot, not the maggots, the flies in the bag. The big inky fly, yeah, man, in the bag. I had to leave, get some face mask, put on with some perfume and go back to do the triage because I couldn't do it. And then we ended up putting her in our catheter room and have her hanging out there for a little bit until we were able to pull down the dressing and everything. And it never looked good. So when I was here in the state, I got a call. I was doing resource at the time. So I was team lead and we got a call that there was a patient that was coming in and the patient has maggots. And I was like, maggots? Anyways, I'm always prepping for the worst. And people will always say, why you always do that? And I'm like, I don't know if they have a code coming in. I don't want to mess up myself and I want to make sure that I'm giving the best care. So when I go in for work and they say that they have an ambulance coming in, I always ask information like, oh, well, is the patient? Is the patient oriented and alert? You know, what is the concern for the patient? And then from there, I will know whether or not I'm going to put on full, you know, just like COVID. Not the white ones though, but I'm going to put on a gown. I'm going to put on my mask And I'm going to put on my eyewear, my gloves, and the bed, I'm going to layer it. Because once we're finished cleaning up the patient, I like to see my bed looking white and clean. So they're always complaining. They're like, why you always do that? Why? And I'm like, to each his own. This is just my preference. Sometimes I see patients coming in, they're vomiting, we're intubating them, and by the time you go down and the patient, it's like a lot of blood coming out. And then before you know it, some persons get messed up. They have to go and change off into hospital gowns. So I'm just prepping ahead of time to prevent that. And plus, when you're doing your EKGs, you don't want to be there doing something like this because the patient is all messy, full of poop or anything. It's the same thing when you're doing a catheter. You don't want to be doing something like, oh, no, I don't have time for that. You understand? So I always put on my gown, my plastic gown and everything, and I'm just waiting. So when they said that they have this patient coming in, I was like, okay, no problem. Went and lay out the bed with the incontinence pads because I love the incontinent pads. Those, I can't live without them at work. I cannot. So I go and layer my bed because I love to have my draw sheet, the white sheet on the bed. I love the draw sheet. I don't know how many persons like that. You have to have I always put the draw sheet on. And yes, it just makes things look a little bit better and easier for you to manage the patient. So when I went in, so I was there and they called to say that there's a patient coming. We're going to put the patient in my room because it was bigger. Because when I hear maggots, I'm like, okay, then this can't go in a small room. It's a big problem, this. So I went ahead, layered the bed and everything, waiting. When they brought the patient was on a non-rebreather bag. And the patient was wrapped up. You know, EMS do their thing. They wrap up everything. If they could wrap up the patient house and bring it some days, they carry every single thing. So this patient, they carry the patient. And like I tell you, we couldn't really see much. We just seen the non-rebreather bag. And there were tons of white sheet wrapping up this patient. So anyways, I went in. Everybody else was just hanging out. I went in and get the report. I was standing up there. So now it's time for us to transfer the patient. When I was there now, because I have on my plastic gown and everything, double up my gloves, and I'm ready to transfer. I'm ready to work. So I was there and I was moving over. But then, when you're lifting a patient and you're expecting the leg to be moving as well, but there was no leg. There was nothing. It was like a bunch of sheet just falling apart. So anyways, we moved the patient over and I was like, okay then. But because the sheet and everything on the bed was white, while we were removing, the first set of sheets, I only see something about the size of, we're gonna say about the size of this little finger, doing something like this on the white. I'm like, what is that? It was like a little, we're gonna say a slug, because that's how it did look. It was so juicy. It was black and just crawling on the white incontinent pads like this. And I'm like, what's going on here? At that time we had, I think it was about 4 persons at the time, because 2 were over that side, because we were thinking that based on the amount of, sheets and everything we saw, it was a lot of, the patient was heavy. By the time we're there doing that, removing all of those sheets, the entire incontinent pads, I vomited in my mask and ran out of the room. Because I've never seen anything like that before. That was one of my worst cases in the emergency room. I've never seen maggots that big before, just crawling like this on white sheet. At that time, when I tell you, everybody was, because the culture here is a little bit different. We have folks who are very, very personal. I love my patients, I take care of them, but I'm not going to really be hugging up everybody that I see. Like, no. That's how you get lice and ticks and all them stuff there from patient. Not saying, the patient, but we don't know what they have. But it was at that time, like, everybody was like, they're pulling over. And I'm like, we're a little bit too personal sometimes. It can be personal, but know what you're digging down in and know what you're hugging up and all those things. Or prepare for it. That's why I put on my gown. So that way I don't have to feel as though, when we hear that, this patient has scabies, no, I have to be like, oh Lord, what am I going to be doing? No, it eliminates, it makes me a little bit more comfortable when I, put on all of that layer in anticipation for my patients. So anyways, we were there and the nurses know, everybody started running. Everybody started running. And I was like, oh my word. So I went outside, changed my mask and everything, and decided that, you know, it's time to go back in because we have to clean this lady up. But anyways, by the time we finished, she was, she had a catheter in that wasn't changed for the longest while. So they picked her up at one of those motels. So apparently somebody smelled something in the motel and decided to call the ambulance. They kick off the door and they brought her there. That's what I was saying. They brought her wrapped up in every single thing. So we cleaned her up, take off everything, only to realize it was, you know, she never had any lower extremities. The catheter, the only time I've seen this kind, like the urethra of a patient was, I see it like once before. It wasn't the urethra. The anatomy, you know, the anatomy when you're looking at some textbook and you just see the string of the, I'm gonna say the penis, you know. There was a patient who had, what the patient had again years ago. And I tell you, he ended up passing because sepsis was just like, you know, but the only thing you could see was like the string of the penis. And that was it. And this patient was the second patient I saw up close where I could see like the urethra, like there wasn't anything down that section. She never had any leg. Her bum and everything was gone. Like there was just bone, and like when I tell you, the dressings were like so black like this. It seemed like for years it wasn't changed, but I was told that she had, you know, they had home health and she was just so rude. Nobody wanted to pick her up. And so she never had her dressings, her catheter changed for months. But anyways, we were there and we finally cleaned her up. There was one nurse who, and that's what I'm telling you, everybody has their calling, you know. Them have them calling out there, you know. There was this nurse who had a lollipop in her mouth. And the nurse, she is a wound care nurse. She says she loves wound care. But anyway, she had her lollipop in her mouth and she went into the room, and I tell you, she was the only person that got in there with the patient because nobody couldn't do it. Nobody couldn't do it. Like she went in and she described it as a different ecosystem. It was like an ecosystem, she said. And she was just there, like we were standing outside because it was a glass door. And I was like, I don't even know where to start. I don't know where to start with this patient. But anyways, because she was rude as well. She was so rude because when we were trying to clean her up, this lady started like cussing at us. And so that's how a lot of persons left the room. A lot of persons ended up leaving the room. So like I went there and I was looking, and this young lady was just inside there, you know, doing her little thing, cleaning, taking every single thing out in terms of maggots. She counted every single one of them. And she did pack. We put in a new catheter and then sent her over to CT scan to get some scans done. And then I think she ended up passing a couple weeks later after we sent her to ICU. She ended up passing a couple weeks later. But the thing is, sometimes when you take persons out of a certain environment and then you disrupt whatever is going on, is that their body, let's just say the body get accustomed to it. So what happens is that the patients die afterwards. That's what you know, you take up some persons and you say, okay, then let's clean them. You know, bathe them, clean them. And before you know it, all you did was, you know, just disrupt their system, their ecosystem, or disrupt whatever is going on with them and cause them to die a little bit faster. So I feel like that was it for her because she never lasted that long. But it was the worst case because, as I say, it was more like you could see her chest, but all the way up to this section was gone. It was just like dressings that were covering, and the dressings were so black. So it hasn't been changed for like months. And I think they had called, what they had said was, you know, like the ambulance was called previously, and it turned out that she always refusing to go to the hospital. She always refusing to go to the hospital, but nobody was seeing her from home health just because she wasn't the nicest person. But either way, that was the worst case I've seen to date. The thing about that situation though was when the patient went to ICU. The patient went to ICU when the nurse wrote that, you know, all 4 extremities were intact. You understand? All 4 extremities were intact. And that's the thing I always say. Like, make your free notes. Document clearly. But because you can't say the patient have 4 limbs when the patient didn't have any lower extremities. They never make any mention that the patient came in, how the patient presented. They make it seem like this patient presented like a whole body, presented no maggots, nothing at all. And that's how sometimes we go to prison, you know, because you can imagine if some relatives see that note and decide, say, yeah, man, no, it's the time to go ahead and do some lawsuit. Because, see, you document that you have 4, the patient has 4 limbs, but no, we only have 2. We only have, you know, the upper extremities. What about the lower? But the documentation of initial arrival is showing that this patient has what? 4 extremities. So it's very important for us to make sure we document, you know, clearly. When I finished charting, I did make mention of what I saw. I did talk to the nurse and have her fix the notes because the ICU nurses weren't even aware of what, because it was after they were calling and making a complaint about it, that how is it that this note is looking like this, but yet still the patient is, you know, looking different than what the note is saying. So make sure your notes represent your patient and not the regular, you know, all 4 extremities intact, skin intact, patient oriented and alert. No, write out a little bit more detail, especially for your first encounter for your patients. Make it very clear as to how the patient presents to you, where they have wound. If you can't describe the wound, just make sure you make a notation that there's a wound there, and then from there. But don't leave it that, oh, it seemed like the patient looked normal, when clearly this patient only have 2 extremities, upper extremities. The patient don't really have a back. You understand? Just write it how you can remember it. So that way, when years later, months later on, they say, oh, let's talk about this patient, because the relative is, you know, filing a lawsuit to say that we amputate the lower extremities. At least you can say, well, when ambulance brought the patient in, the patient was wrapped in multiple, because that's how we describe it, multiple layers of, you know, sheets. And then there was maggots crawling. The patient never have any extremities. Describe the dressings. They were black, large slugs. Not slug, but, you know, maggots. And just describe it as how it presents to you. And then from there. So what has been the worst shift you've had, and what was your worst experience on that shift? Chun, how are you, amigo police? But I like when my shifts are very busy. So I like when my shifts are very busy. I love the crazy shifts, working in the emergency room and having all of those crazy shifts. Trini gal. Okay. Which shift you think has the most drama though? Which shift always have the most drama? I feel like most of these questions are geared towards day shift. Day shift has the most drama, right? That's what I feel. There's just so much going on day shift. I don't know. It's always the heaviest shift, but it seems like they always have a lot of drama going on day shift. Why? I don't know. Probably because some people not doing them work. I don't know. Any advice for someone going to write the NCLEX soon? Start doing a lot of case studies. Look at your case studies, the multiple patient case studies, because that's what they're doing. And I think they're focused more on, look at your rationale and try to understand the rationale. No, don't just be studying and say, oh, the answer is A and move on. Find out why this answer is the correct one, why this one is the safest for the patient. Look at the other options and see why it's not. And then do the multiple case studies, because those are going to be, similar to real life situation. I think the new NCLEX, they've changed the whole thing regarding the perfect. It's still the perfect world, you know, in a sense. But the perfect world scenario that normally be doing, I don't think that is what they're doing much of. They're trying to paint this real, you know, the experience that you will be getting on the floor. They're trying to give you that kind of experience. So you have multiple patients, different things going on. And you, in all of the chaos, the mess that is going on, you have to try and figure out how you're going to manage the patient. And then when it comes on to, you know, like your lab values, yes, lab values are going to be there. But like, say, for example, a patient is having muscle weakness. What lab values you're anticipating to be low? If a patient is having palpitations, what lab values are you anticipating based on the, you know, the scenario or the patient's condition is going to be elevated, or what could be contributing? So look at, I think they're going to be trying to make sure that the scenario that they give you can look at EKG, cardiac monitor, lab values, and then put all of that together, because it's all about critical thinking and diagnose your patient, manage your patient. So don't just say, oh, this patient is hyperkalemic, and you know that, yes, the range is this. What are you looking for on your EKG to say that this patient is hyperkalemic without you looking at the lab result? All right, so try and study a little bit more like that. So the multi-patient case studies tend to have that, you know, set up, and that's what they're doing. And then most of the questions are going to be like linked. So like A, B, C, one question, A, B, C, all of them link. So just in case, like, so for example, if you know, if they were supposed to ask you how you diagnose this patient, what you're going to diagnose the patient with, and you decide you're going to diagnose the patient with dehydration, the other questions are going to be linked to the diagnosis. So you just have to try and understand the pathophysiology of certain things. So whenever you see the scenario, you're able to answer the question properly and manage based off, you know, the diagnosis there, and answer the remainder of the questions. But it's more real life. They're trying to, you know, give you an idea of, because when some students get onto the floor, that's where they get the confusion. They have this confusion about, you know, what to expect, because the NCLEX is already telling us it's the real world. There is no other patient that you have, basically. You're not short staff, you're not this, you're not that. But when you get out there, it's just a lot of chaos, you know, you're having to deal with. So in the midst of the chaos, they want to see how safe you are. At the end of the day, it's all about safety. Yours is 17, but you don't think you're underweight. Depends on your height. So it depends, because you have some persons whose BMI is, because, you know, just think of it. Some people have big bones. So it depends on your height, your weight. So I don't always go with it, but, you know, when you're going to the exam, that's what they're going to be using, textbook. What are your views on using bootcamp as a quiz compared to the UWorld or Archer? I've only used UWorld. I was using UWorld at one point. I don't know about the others, honestly. But just find one that you prefer. If you haven't purchased any as yet, I don't know, I would probably go with UWorld, because I did like how they do their questions, and they have, like, you know, sections with additional information that you can learn about the conditions as well. So I don't know if the bootcamp is just questions only, but UWorld did have additional resources or information for the system that you're studying, or the questions that you're looking at. So I would say probably go with that one. But other persons, you can probably try other persons and see what they say regarding the other resources for review. But, you know, it's all about how you use the review course though, okay? So some persons will use bootcamp, some persons will use Archer, you know, and they're still going to exam and fail. So it doesn't matter, like, the resource, in a sense, is what you get from the review itself, how you use it. Just find one that you prefer and stick to it, answer the questions, and make sure you look at the rationals. Don't rush through it. And from there, hopefully that will prepare you for the exam. Not a problem, not a problem. Yeah, because some persons, as me say, you know, they will have all these resources. They're working with Archer, they're working with UWorld, and it confuses you. So you don't want that confusion before you go into exam. Just find one review course and don't use one review course, and you have other, like, you know, you have a textbook that you're using, but not multiple, because it's not gonna make a difference. Just find something and stick with it. Get the information from it. Because if you're gonna be looking through 10 different resources now for one condition, you're gonna confuse yourself to get in that when you get into that exam. So just try find one review course and just work with it, and then from there. Saint X, hola, how are you doing? Thank you for the follow. You need to go to your bed. So that's just what I would suggest on that. Okay, nice. Saint X. All right, I would say that the shift that has the most, the best teamwork is night shift. Who is here? No, not no. Yes, Ariane?
Echo Daddy on your phone.
So in the meantime, I was just asking about the day shift, night shift, which one you guys prefer. But in the meantime, you can also ask me any questions. Feel free to do that. Oh, that is on the phone. Yeah. So which shift has the best teamwork? I say for me, it's night shift. But you guys can let me know in the comment box which one you think is the best for international nurses, new grads, or in general just for you. Which one you think is the best shift out there in terms of teamwork? Don't do that. Carousel, welcome. When you start working? Oh, not yet? Okay. Do you have a shift that you plan to work with, or anything that comes, you'll go with it? Close my door and go to your bed. All right, let me ask you, which shift, I see 10 persons on the live here. I don't know how many persons are nurses. Which shift persons tend to steal the snacks on? Who tend to lose a lot of snacks on any shift? Which shift you normally lose your snacks on? Who normally eat out your food? Day shift or night shift? I think night shift is the one that, yes, GMAC. Night shift is the shift that a lot of persons tend to lose their food on, because a lot of persons don't come plan for, you know, for lunch, for dinner, or let's just say supper. And places are not open, depending on where you're working. That's another problem. So persons tend to bring their food and other persons tend to eat it. So cafeteria is probably closed a lot of times at night. Some facilities, they have cafeterias that closes at around 10, 11 o'clock, thereabouts. But some places, the cafeteria closes very early. So night shift is the shift that a lot of persons tend to lose their meals a lot, because persons tend to be eating from the fridge or from the lunch bag. Even the resident MDs come for snack bag. Okay. Okay, yeah. And which shift you feel like leaves the worst notes? Which shift gives you the worst notes? Nurses' notes. Which shift gives the worst nurses' notes? Night shift? Yeah, night shift tend to give the worst notes. I don't know why. If it's probably because we're just so tired on night shift after probably like 2 o'clock, 3 o'clock. So yeah, but night shift, the notes are not always good on night shift. A lot of persons don't really spend that much time and do their notes. Sometimes on day shift, depending on sorry. Depending on how busy the department is. But I feel like night shift is the one that always give the worst notes. Sorry. And then which one gives the worst handoff? Which shift gives the worst handoff? Day shift, night shift. Day shift, because everybody is in a rush to leave. A lot of persons are just over. Once it touches 5 o'clock on day shift, it's like the shift has ended. Everybody is just like ready to go home. You have 2 more hours remaining, you know. But everybody is just so in a rush to go home. You realize that medication's not given because everybody's like closing off their charts from early. Yes, at 6:30 they're done, or 7:30. So you realize that they're closing their charts from early, and it's just like And then I guess probably because, you know, you tend to have a lot of emergencies around that time. In the mornings, 5 o'clock, in the evening, 5 o'clock as well, is when you tend to have like a, you know, the ambulances tend to come in a little bit earlier around that time and kind of mess up your shift on mornings and night shift. So even when you're planning to go, you're always either doing a code or something by 6:30, 7 o'clock. Which shift actually gets lunch breaks? We're going to say night shift, because after an admissions, you're ready to leave. Yes. You leave all the admissions on day shift at 5 o'clock. You don't want to do any admissions. If you're on the floor, you don't want to accept any more patients from the emergency room. That's always a struggle. The phones don't, you know, nobody not answering the phone as it reaches 6 o'clock because they just feel like the emergency room is sending them patients. So the phones just ring. And everybody is now annoyed, upset with the emergency room. I'm talking, you know, from experience here. Everybody is upset with the emergency room department because patients are still coming in. They still want to send out patients. For me, the cutoff time for, you know, transferring a patient to the inpatient setting is 6:30. I think it's fair because the emergency room, we're always accepting patients. We don't really have no cutoff time because sometimes you probably have your handbag and you have to put it back down because an ambulance, a code comes in. You can't really leave and the patient is unstable. You still have to get cracking. So when it comes on to 6:30 for me, I try not to call the floor. If it is, you know, quiet. If it is quiet, if the department is falling apart, yeah man, we still are calling because we need to decompress our emergency room. We don't have any beds. I'm going to be calling and getting that patient up because you don't have to, I just believe that you don't have to admit the patient. Just get the patient comfortably in a bed, get some vital signs, yes, patient oriented and alert, and hand off the patient in those situations. But I always stop calling at 6:30 if I have beds. If I don't have no beds, I'm sorry, the floor is going to get upset. They're going to get upset. The patient is coming to your floor. The patient is coming to the bed that is assigned. You understand? So I'm not going to be calling after 6:30, but if we don't have any beds and the department is crazy, you guys have to take some of the craziness too. You understand? So the patients are going to be coming up there one way or the other. When I was in Jamaica, they never really liked that. I don't know how many Jamaican nurses here that I've worked with at Mandeville. Yes, I was well known for that because our emergency room, just think of it, our emergency room was more of let's see how many beds.
6.
I'm gonna say probably 10 beds we would normally have, but we never have ambulances that are calling to say, hey, patients are coming. It's usually like patients coming in or family members taking patients. You have the police sometimes will be taking patients to the hospital. It's not like you get a heads up. So when we have 0 beds and we're talking about even hallway stretchers, we don't have any bed. By right, that would have been the emergency bay, probably could have been an 8 bed, but we don't, it's not like, you know, it's curtains that separates the emergency room beds. So when we have no room to put patient, that section can hold up to, because when you talk about privacy, it's very limited. So when you have the 8 bed, it's like, say for example, it's supposed to be an 8 bed or 6 bed, just thinking about the Bay Area. And when you push 15 beds down that side, yeah, whenever we have beds on the floor, the patient needs to go because we need to decompress that area. And it's not like we have a lot of nurses. It's just probably like 2 nurses down that side with 15 patients. And when I talk about 15 patients, we're not talking about 15 walkie-talkie patients. We're talking what we call flat patients. Yes, not much they're doing. Critically ill patients. So the patients need to go, because before you know it, you hear that, oh, there's a shooting, there's a stab wound, you know, you have a hypertensive patient, somebody pass out, that needs a bed. So in the event that we need a bed, what is going to happen? You can't do anything. You can't do anything. You just have to send the patients up. The nurses on the floor tends to get upset a lot of times about it. But, you know, nursing care continues. We need the bed for somebody else. But sometimes persons don't really think about it like that. They just think that, oh, the emergency room supposed to still continue even when you don't have no beds. I understand, but when you have a bed on the floor, you can't shut off the bed from 2 hours and say you're not taking any patient in there. What is going to happen in our emergency room? You're not going to have the patients go moving. And that was one of the problems I had at the last facility that I was working at. And I was like, no, this is just too much. This is just too much, because I was working in this 5-bed cardiac hospital. And it was just 1 nurse, 2 nurses, 1 doctor. We never leave the department. We always be working and having lunch at the same time. We never really get a lunch break. When you talk about your LVAD patients coming in, ambulances coming in, anything cardiac, they were just coming in through that hospital. We were also responsible for, so that cardiac hospital, there was a major hospital that is close by that we still take patients from over by the cardiac hospital, and they have to come through the emergency room most of the time, because, you know, healthcare in America is a money-making thing, so they run them through the emergency room just the same. So we still have to see those patients, even if they're going to ICU. They really understand the maths, but, you know, just a work with it. So them say it's supposed to be done, you just work with it. So the patients coming from the other facility going to ICU, they come through this emergency room. We still have to work them up, send them upstairs. But the thing about the 2 nurses in the department, we never leave the department. We were always stuck in the department. That is on the phone. We never leave the department. We never had a tech. We never had an operator. We never had housekeeping. We have to be doing everything. So just think of it. Two nurses, a doctor. When you have the LVAD patients coming in, a lot of times we don't even know that the patients were coming. A lot of times we don't know that the patients were coming in. A lot of times when admissions, patients are being accepted, we don't even know that the patients are coming in. You only hear that, oh, there's a helicopter that is like, you know, 30 minutes out. And we're like, okay, then who's coming? Where coming from? Because even the doctor in the emergency room, a lot of times, didn't even know that he's getting a patient or a patient is being accepted, because they had this weird thing. So even the doctor in the emergency room don't even know that he accepted a patient or a patient is coming to the emergency room. That another facility is not able to take care of. So they're transferring the patient. And that was the reason why I left that hospital. I left that hospital because it was too much. It was so risky. Like you can, you know, some risk you can run. You'll be like, okay, then yes, on a slow day. But there are days when it was just, it was just too much. It was just too much. And because I am protecting my license, the only way for me to protect my license is what? Document. So almost every day, because you only have 5 beds, you have 5 chair. That's how they, they were doing it. 5 beds, 5 chair. The waiting area had about 10 chairs that were like literally they screw them down in the floor. So the chair's gonna move. And then we had, so when we have EKGs, for example, you have a patient coming in, it was more of 2 nurses, 1 doctor. So even if we have the 5 rooms packed, when patients see or when persons see the H sign to say it's a hospital, whatever is going on, they're showing up there, right? You're going there because it's a hospital. So even though it says heart hospital, if they're having vaginal bleeding, if they're having stroke-like symptoms, if they have it, whatever it is, they are coming there. And you cannot say, oh, well, no, this is a heart hospital. You still have to register them. So even when we have no beds, we had to register them. And then the other thing about it is that because it was a small hospital, you have the folks who are, in upper management. They just feel like, oh, the friends, let's say at one point, one person sent their friend over to the hospital because they were playing pickleball and broke their ankle. Remember, heart hospital, we don't have resources over there for anything except heart and another specialty. And they send the patient over there, and knowing that the facility is not orthopedic, we don't have nothing named splint, nothing at all. But yet still they send them over there with the expectation that, oh, they'll be out of the department in like under 2 hours. So anyways, because we were there now, and as I said, the rooms were packed, that patient was on a stretcher because we got the call that, oh yeah, we have a VIP coming in. So I said, oh, I saw this place go. I saw it run. All right, we're going to put the VIP in the hallway because the VIP could never go in any of the other rooms. And that's how I always look at, like, you have to be like certain things, you have to be critical about certain things. So sometimes people will be like, oh, why you put the patient there? Okay, and then when a patient comes now that really needs a room with a monitor, where are you going to put the patient? And so said, so done. Because when we moved the patient, we had like patients that were transferred in. We had one patient that got accepted to go the operating room. You understand? The patient was supposed to go to the operating room, that not even the cardiologist didn't even know that the patient was in the hospital that he was supposed to be seeing. So that patient was there. We had renal patients that get transferred over there. Like, it was just so chaotic. And it was just 2 nurses. 2 nurses, 1 doctor. So every day I write report. And the thing about it, the floors, they had this thing that, oh, we're not taking any patients after 5. We're not taking any patient after 5. Exactly. Every single patient that comes through the door is VIP for me. When they showed up the day, they were like, so they never did like the idea that the VIP was in the hallway. And I'm like, yeah, there's nowhere to put the patient. Eventually, the VIP, because we were waiting on orthopedic supplies from the major hospital, because we never had anything to splint or anything. So that patient ended up staying in the hospital for a few hours. We ended up moving the VIP from off the stretcher because the ambulance was coming in. We never have anywhere to put the patient. That patient that was coming in, heart rate was in the 150. Yeah, we needed a patient on a bed. We had a patient who was having shortness of breath, heart rate of 145, sitting up in a recliner. It was chaos. Sometimes we are moving patients out of our room, pushing in this one just because we need a cardiac monitor. Because we never had any space on the floor, but the patients were just being admitted or accepted. But we weren't even aware in the emergency room. Never aware. So that when I left the hospital, it was a little bit. It was getting too much, and I was like, no, because we never had any beds for a couple of weeks. Well, almost 1 whole month, we never had any beds in the hospital. But the facility was still accepting patients, and what they did was they accepted a patient on Like, so for example, the patient was supposed to go to ICU. The patient was supposed to go to ICU, and the ICU denied the patient because the patient never technically meet the requirement for ICU. But you know, when everywhere friend, you know, this friend thing, friend, yeah. Everywhere you go, you will realize that friends will make things work for you. So they decided that because they know somebody who work at that facility, they wanted the patient to come right at that facility, nowhere else. And so they accepted the patient. But so ICU had denied the patient because they never had any beds. Because as I said, we were on lockdown, beds, no beds for couple weeks. Well, no beds. We were transferring patients out. We had patients in the emergency room for days. You know, can't get any beds at any other hospitals because the area was like so packed, and this is like a busy area. And they went ahead and accepted this patient just because the friend is in high position. So they went ahead and accepted the patient. But this patient was like 6 hours away from where the hospital was. So they airlifted the patient. When the patient got airlifted to the hospital, it turned out that the patient apparently thought they were going to ICU, but only ended up in the emergency room. They were in the emergency room for a while, you know, keep them updated, move them on a hospital bed and all of those things. They were there from the night. I went in on the day shift and saw the patient. Let me tell you, say, I clean up the patient. I take off, because this patient is supposedly ICU, but she was still in her street clothing. For the whole night, she was still in her street clothing. And this is me. I don't like the patients in them street clothing, especially if they can't do anything. They can't do anything. So this lady was still in her shoes. And it's a couple hours, well, you know, a lot of us are guilty about it. We are so guilty about it. The patient was still in her shoes, her stocking. She still have on her jeans with her belt. And I'm like, how is it that we even get EKG, you know, cords under the patient's clothing? Like, this don't make no sense. The patient was intubated. Like, everything was going on. Everything was going on. But this patient was still in her street clothing. So anyways, I went in and I explained to the patient's relative that, you know, this is what I'm going to be doing. But the room is so small. It was more like a sardine tin. The room was so small. Just think of it. You have the patient on a hospital bed and you have one chair. When you open the door, the chair was there that was, you know, preventing the door from opening. It was just so small because, as I say, it's a 5-bed emergency room. And we went ahead. I went ahead and I told her that I'm going to change her off. I don't know if she wants to step outside for a little bit because there's no room for her. Because they have the machines and everything, the computer, there was nothing there. So I say, you know what? Let me go ahead and change off this lady, get her into a gown and everything. I did that. I had another nurse came in and do that. Let me tell you something, me sweat because the room was so tiny. There was no like windows or anything. It was just so tiny. And then the lady was asking, like, you know, when she's going to go to the floor, blah, blah, blah. I explained to her that, you know, we don't have any beds right now. I called the house supervisor, find out. House supervisor say, well, the patient is going to be there for the entire day. As I said, this patient came in like from the night before. And this is like morning. No, I explained all of that to her. You know, she really liked the update that I was giving her. And like by 11 o'clock, I called the house supervisor because I just want to have something to document, you know, because nobody not going anywhere. 11 o'clock, I call again. House supervisor say, yes, the patient is going to be there until tomorrow. And I'm like, okay then. The relative is now coming to ask what's going on. And I try to explain to them that we don't have any beds. And they're like, what do you mean by you don't have any beds? I say, we don't have any beds in the hospital. We don't have any beds in the hospital because that's what the house supervisor told me to tell her. I know that from before, but I never really go tell her, say there is no bed in the hospital. So anyways, I told her that they're working to see if they could get her to the floor in the evening. She was upset about it, but I never really know the extent of her, you know, how upset she was. But, you know, by 2 o'clock, I get a call. They wanted to talk with the manager for the department. We're no manager, you know. But I made it in charge of the day. So I said, there's no manager. We just have 2 senior nurses here. So they're like, oh, how is it that you don't have a manager in the department? I'm like, no, we don't have a manager for the department. You understand? We just have the whole supervisor, senior nurse, and that's it. And anyways, he was there introducing himself, telling me that he's a doctor. He's been doing, like, he was just so disrespectful, shouting. The nurses station is very small. So you have the doctor, the nurses. There were 2 nurses and another nurse that was orienting and the doctor. So because of the tone and everything, you know, I'm saying, no, let me just kind of put this thing on speaker because I can't deal with the sound in my ears right now. Anyways, I was there and he was telling me that he's a doctor working in this area for how many years and he has never heard of a hospital not having any beds and blah, blah, blah. So I said to him, I'm sorry to, you know, cut you, but I don't want you to keep on shouting at me like that. I'm going to be tempted to hang up the phone. And he's like, do you know who I am? Do you know who I am? I'm like, you already done tell me. You already done say it, sir. I'm just saying, if you keep on shouting at me, because I'm not the one that is, you know, interested. I'm not the one that is accepting patient. I'm just the nurse that is giving care. So I am not the one. So I was saying to the doctor, if you want, you can talk to this gentleman now because I'm going to hang up this phone call. Because I don't come to work at daytime for anybody to be showing, you know, to be shouting at me and behaving like I am the one that is accepting patients in these hospitals. I just come to do my, you know, my nursing duties and that's it. So anyways, he was like, no. So I said, okay then. He was there still shouting. I said to him, I'm going to hang up the phone and just hang up on him. So anyways, he went ahead now and called. And that's the thing about privilege, you know. He went ahead now and called. Like he found out who the doctor was that was supposed to be accepting patients in the hospital, like on the floor that the patient was supposed to be at. And then he started blowing up this doctor's phone. Lo and behold, the doctor don't even know that the patient in the department, you know, because they never accepted any patient. But because, you know, oh, I am a doctor and I am working at this hospital, I need to speak with this doctor. Probably everybody just decided to go ahead and give the number for that doctor. Anyways, he went ahead and he blew up the phone of the doctor. Then he went ahead and he called the whole supervisor, and I tell you, he dished it out to them up there. So anyways, they told me, don't answer any more phone calls from them. They're going to try to get, you know, the head, whoever is accepting patients, to come and speak with these relatives. So anyways, at the time when I was changing the patient, there were, as I said, there was one lady inside the room. She was standing. She had her nice little, a Mew Mew, them call the bag. M-I-U. Yes, Mew Mew. She had her nice little Mew Mew on her chair. And I said to her, she said to me that she has some relatives that are coming. Remember, tell us that this is 6 hours away, this patient come from, you know, airlifted. So I said to her, that's fine. Just that when they get here, we have 0 chairs. There's no more chairs. So what I would encourage you to do is just have them come into the room and we can just, you know, chit chat for a little bit. And then we can only accommodate 1 person in the room because the room is very small. There is nowhere to put any extra chairs or have persons hanging out. Because as I say, when you open the door, it is pushing against the chair as well as the bed of the patient. So there was no room for anything. Anyways, I thought she understood that. It never looked like she liked it. You know, I think probably with everything that has been going on with the wait time, she was like, yeah, I'm not going to be tolerating this today. Because they thought they were going to go to the floor. So I was like, okay then. I explained that to her and I thought she understood that. So lo and behold, the doctor called back because he didn't stop calling. He never stopped calling. So the doctor answered and put him on speaker, and he wanted to know who the nurse was because he was going to report the nurse because he said that me not have no manners. So I say, okay then, like, me can't deal with this again. I cannot deal with it again. So I just tell him my name. You understand? I seem like when you give out in credentials, and just give out my credentials too. Come work hard for it too. You understand? So anyways, I was there and I gave him my credentials. I said, my name is whatever. So I don't know what he was planning on doing with it. So anyways, I we were there. As we said, none of the patients ain't going anywhere. Everybody was in the department for a long time until I saw our, what we call, it's not the CNO. Somebody that is like higher than the CNO came into the department. And when the person came into the department, like I was at the front because based on where there was one that is one nurse that is facing like the triage, a little waiting area, and one nurse that is facing all the patients. So she showed up, and this was the first time apart from when I was doing orientation, I am meeting this lady. And I never really meet the lady. I never really meet her on orientation because it was like a big orientation for the facilities. And they say, who is going to be working at this facility? I'm put up my hand like this. You know, me put up on the back bench. So I put up my hand like this. And there were a few persons who did put up their hands. So we never exchanged any words or anything. So when she came, she said hi. And she said, you know, I said, hello. And she says, where is the patient? She never asked anybody at the nurse's station what was happening. She just asked, where is the patient? That is supposed to go to the floor. So I'm like, okay, then the patient is in, this is me, the patient is in room 4. And she said, okay, thank you. My name was on my ID. She said, thank you, Stacy. And then she went in, and when she came out, I don't know how many persons know the red crash cart. Yeah, man, she came out under here because in the room hot. In the room is so hot. It is so small. So when she went in with her nice ugly hairstyle, she come out looking so wet. The face looking flushed. I don't know what was happening. The doctor was like, I wonder what happened in there. And I'm like, I don't know. But pity, I never know that I'm the problem. I never know that I am the problem. So anyway, she came out the room. She never said anything to anyone. She just asked for, well, before she did that, she left. She asked for a chair. I said to her, we have no chair in the department. We have no chair in the department. There was one chair in another room, but the patient relative had left, and so they were coming back. So she said she wanted some chairs for the patient's room. I'm like, there's no more chairs. Like, you guys give us 5 chairs, 5 stretcher. Like, where do we get chairs from? There's no more chairs here. The other chairs are in the waiting area, and they're literally screwed onto the floor. So I was there. So she asked for the chairs. I said, there's no more chairs here. So she went ahead and took the chair to the patient room and brought it and put it inside of the patient's room. When me tell her, say, I'm there and I'm like wondering, where is she putting the chair? Where's she putting the chair? Anyways, she called in the 5 relatives outside, and everybody had come into the room at the time and was there. So she brought the chair in. And then I saw the patient's relative come out and, you know, they look at me like, okay, then yeah, I got a chair. You said there's no chair. Well, we got a chair. And I'm like, okay, then, you know what, whatever, can't bother. So she left. She never said anything else to any of us. She never said anything to the doctor. She never said anything to me. She never said anything to the other nurse or the nurse that was on orientation. Nothing at all. She left. And after she left, about 20 minutes later, the whole supervisor, and you can see that it burned her, it hurt her. Oh my word, she came down and she went in the room with someone else and pushed the patient out. The patient got a bed up by ICU. How did that patient get a bed up by ICU? I don't know where they put the patient. If they put the patient in an alley, I don't know where they put the patient. But the patient got a bed in 20 minutes after she left the room.
I'm sorry, I didn't quite catch that.
Give me my phone. Please? So the doctor was like, so where was that bed? But what about this patient that has been here for 2 days? Why this patient don't get a bed? Why did this patient who come like a couple hours ago, like overnight, just the same, got a bed? You understand? We understand, say the little fuss now is causing all of this thing. Can I have my phone, please? It's causing all of this. So you could see the whole supervisor was so upset. She was so upset. And I understand why she was upset. She was so upset about it because no, we were the ones, because initially we were telling the whole supervisor had given them the, you know, the option of being transferred to another facility. That's the other thing. we had told them that the only thing we can do right now is transfer the patients to another facility, because based on the patients we have in the department and the priority for the rooms, she wouldn't be the one that is getting a bed today. You understand? It was a case where if somebody died or something like that, then probably additional rooms would have been opened up. But we have patients in the hallway who needed bed on the floor that never got any bed. So the supervisor, I told them that we can transfer them to another facility, but they never liked the idea of being transferred to another facility, because that would have been the third emergency room bill they're going to be jacking up in less than 24 hours. So they never liked that, and so they were upset. So I was like, okay then. She went upstairs with the patient and put the patient. I call and I'm like, where did that bed come from? And she's like, you know what? I'm just gonna write a report, because she can't deal with it. She cannot deal with it. So I'm like, okay then, fine. I went ahead, and during everything I have been doing my notes. I've been doing my report. Yeah, man, because this one, I know it was gonna come back at me, because as me say, she never said anything. She never said anything to me. She never said anything to the doctor. Nobody at all. She just went, and there was a bed. There was a bed all this time. So anyways, she went up and did her thing. Everybody was just upset about the whole, how it was dealt with. And that was it. That was it. So it was, let's say I had my annual, my yearly, you're supposed to do your yearly evaluation. So my yearly evaluation was due in say about 2 days. And during this time, as we say, it's a 5-bed hospital, and it's not like we have additional support staff, because we were just listening to the roles that we had to do as the nurses at that facility. So when the major hospital gets labs done in the emergency room, and those patients get tested for everything under the sun, and they get discharged, if they get admitted to the floor, then the main lab would call us over there, because I feel like we're not doing anything. They would call us over there with all the lab results and be giving us those lab results. And I always say that this don't make no sense, because the lab is writing us up when we tell them that, hey, we have a patient that we're triaging. Remember, tell us that this is a heart hospital. We have a patient that we're triaging, but you're calling us to tell us a patient has gonorrhea. That is not an emergency. The patient treated and discharged. You can call us back later on, and I don't see why it was our responsibility to be taking it. So a lot of times we might be having a patient that we're prepping to go to the cath lab. They're calling non-stop. And when you tell them that, no, we can't take the results right now, they're upset about it. They are so upset. They write report from now until thy kingdom come. They call to tell you, oh, the wound culture come back. Where's the patient? The patient get discharged a much week ago. And they just feel as though those are emergencies that we need to take in the emergency room department. And so when I started, I was like, no, this doesn't make any sense. And I was saying to the manager, you guys need to figure out how to do this. Because it can't be a case where the two nurses in the emergency room are taking all of those results. That don't make no sense, because when we are in prepping a patient for a cath lab, the calls are coming in, and when you think it's a call for, a troponin or something, it's a call from the lab to say that, hey, we have a patient who is positive for syphilis. Okay, can you call back? No. And I'm like, I'm sorry, but I'm going to hang up, because it's not an emergency. You just hang up, you understand? So they always get upset about it, and they're always writing report. So my name already done long from here so to Jericho on the report list. And so that was one thing. That was one major problem. The other problem was the floors. The major floors were, the floors weren't accepting any patients. So by 4:30, 5 o'clock, you call in to say, hey, this patient is supposed to come to the floor. The nurses will be telling you, oh, well, we're not taking any more patients right now. I'm like, huh? What do you mean you're not taking any more patients right now? We have 5 beds down here occupied with 5 cardiac patients. The patients need to come to the floor. It's 5 o'clock. Oh, you're going to have to call us back in 1 hour. No, that no work. Can't work. and then they complain that I'm difficult. I'm like, that doesn't make any sense. It doesn't make any sense. So we would normally take the patient up there and give them report. It's not our responsibility to transfer the patient. It's their responsibility to come and get the patients because we are not supposed to be leaving. So the house supervisor would normally just come down and take up the patient because we have no beds still, we don't have any beds for the patients. So they cancel the system that the patient discharged. No, not all the time, because sometimes the patient is coming from outside facility that is not associated. So we call the supervisor, because when we see that the beds are available, we call the supervisor and the supervisor take the patients up. When the nurses on the floor are ready to take their report, they can call us down. You understand? But we always do that. Sometimes what they would do is, like, so for example, we ask for the beds to be clean, like we need the beds, and the housekeeper would go ahead and clean the beds. They clean the room on the floor, and what they do is they would change the thing to say that it's clean, it's ready. And when it's time for you to call report, they're telling you that the room is dirty. So what they're gonna want to do is change the room to dirty. And I'm like, this doesn't make no sense. The housekeeper said that the room is clean, like, about an hour ago. Why is the room dirty? So me with my enough self, because some days I need to stretch my leg. Need to stretch it and see what exactly is going on. You try calling and you be like, hey, we have a patient to come up to the floor. Oh no, the room is dirty. And I'm like, dirty, but the housekeeper cleaned it 2 hours ago. Me is walking up to the floor, because is either one person that tell a lie, is either the housekeeper tell a lie, or the nurses are telling a lie. So I walk up to the floor to get my patients to the floor, but I don't walk up there with the patient because I don't want it to be a case where the room is really dirty and I walk with a patient up there. So I walk up there, and this is what I normally do in Jamaica as well. So now this is like, we transport patient to Jamaica long, like every single time. So I walk up to the floor because it's only 2 nurses, 1 patient, 5 beds, 5 chair. When an ambulance come, where am I going to put the patient? Am I going to tell the ambulance, oh, well, you know what, you're going to have to keep that patient until 7 o'clock because the floor is not taking any more patients and we can't move any patient? No, you can't tell them that. So I walk up to the floor and walk to the rooms that the housekeepers cleaned 2 hours ago, 1 hour ago, and check it. First, I called the manager for housekeeping to find out what's going on, because they keep on saying the floors are dirty. The rooms on the floors are dirty. They're like, no, the rooms have been clean. She checked it. So when I keep on calling, I'm like, there's something going on. Somebody missing something. So I walk up to the floor. The rooms up here clean, clean, clean. The nurses, them don't wanted the report. But so them already said that, oh, me I called. You're calling too often. Yeah, I mean, if you call often, I'm not going to stop calling until 6:30. Because we don't have anywhere to put the patient. You understand? So they would go ahead and write report that, oh, me send the patient to the floor. But it's a good thing, when it comes on to timestamps, I love that. Because it shows when the room was clean. Because then is the house supervisor get the blame, so that they're not cleaning the room on time, And it's unfair. It's unfair. The house supervisors are doing their part, and then you change it and make the room dirty just because you don't want to take any patient at 4:30, 4:30, 5:30, 6:30. So you're supposed to be on the floor for 3 hours doing what? Nah, it no work. You're not supposed to work like that. They usually clean it on time. Exactly, Dorian. They're not supposed to be doing that. So that was the other thing that, oh, you call too often. Let me say, yes, me I call and make sure you give me your name. What's your name, dear? Oh, you're RN? Or what's your your job description, or what's your role? And I write it in the notes, because at the end of the day, somebody must be accountable for something. It can't be a case where we're just showing up and then 3 o'clock you hear that, oh, we're not taking any more patients until 7 o'clock. And what happened to the patients that are coming in? What is happening with the patients? Them sit down and look for me, and them need them nurses upstairs. I've already done my part. I wait for new patients coming in. So that was the other thing. So it was always like, oh, when they hear that I'm at work, them don't like the idea, because I say, Lord, they're gonna have to work today. And I'm like, look, when it comes on to 6 o'clock, 6:30, if you want to put the patient in bed and make the patient comfortable and hand it off to your the admission to your night shift, do that. But you can't be holding up a bed for whole of 3 hours because you don't want to continue working. So they're always so upset. But the supervisors are always coming down. I say, look, yeah, the bed's up there clean for the last 2 hours and they're not taking a report. They're not answering the phone from the emergency room. The supervisor just come down and just send everybody up to the floor, wheel them up to the floor. And I love it. That's the responsibility of the chargers. So sometimes the floor have admission and discharge RN. Yes, exactly. But them make it seem like, oh, no, that's not how it goes. So they always be like, oh, no, we're not taking any patients. So that was the other problem. So anyways, and I always talk about these things with my manager. But you have some managers who are, I'm going to say, the yes manager, them just say everything, yes, 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 yes. Yeah, that was the problem. Them just say yes to everything. Like when, the bigger boss will say something, it's like them not try to explain to say, it's only 2 nurses in the department. This is what is happening. They're dealing with cardiac patients. Them not explain anything. They just come back and tell you that, oh, you need to keep the patients. We say, keep the patients where? Where are we going to keep the patients? Where are we going to keep the patients? It don't make no sense for keeping patients down here when we don't have no bed. We can't keep patients when we don't have no bed. You don't have any empty room. The rooms with the LVAD machines are occupied. If the patients do come now, and it's not like a case where you're getting a call to say that a patient is coming in. It's not a case like that. Now, God bless when you have an ECMO patient come in. Yes, the ICU will know that they're coming. They'll be coming through. But apart from that, the other patients, we ain't knowing anything. And it was just so bad. It was just so bad because the nurses were just not carrying, they're not carrying what the responsibility that is supposed to be doing. All the responsibilities, they're not carrying it when it comes on to their shift. It's like them just hide out the patients. Hide them out until a couple hours. And so when they were there now, where was I know we were talking a lot about the patients there. So those are some of the things that I was dealing with at the time. So back to the patient that got airlifted. So after the patient had gone up to the floor and everybody was upset about it, the doctor was upset because, as I said, she never came and said anything to any of us. The supervisor, the whole supervisor was upset and she was writing a report and everything. I wrote my report because it was just too much. I went in to do my annual, the director or supervisor, exactly, the supervisor. I went in to do my annual, my annual exam. Not annual exam, my annual assessment, where they do the yearly review to tell you how you're doing, blah, 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 what they like, what they don't like. So it was at that time, I was signing off on my evaluation and, everything was, oh, yeah, we like when you're at work. Because they had like peer reviews and then I was reading through and was like, oh my word, everybody was like, oh, they like when I'm at work because it feels, even when it's busy, it feels like everything is just working smoothly. And I'm like, it's because of my experience in Jamaica, because I'm not accustomed to ambulances doing certain things. You're always waiting, because when you have somebody say, oh, we have a van load outside and you have 5 patients in there, and out of the 5 there is 1 that is dead, 1 that is hanging on for life. You're always like very proactive. You're always proactive. You're thinking. So when you go in and you see 10 patients, you scan the 10 patients, look through the diagnosis, and you know already who is going to be moved in the event that you have a multiple trauma coming in. And that was just how I was always programmed. So regardless of how busy the department is, I'm always getting patients through and it just seemed like nothing. So people are always making it seem like, oh, the shift just always smooth. They always want to work with me, things like those. But then when it comes on to the report now, they're like, yeah, they say you call too often. I'm saying, and you have a problem with that as manager? Oh yeah, they say you call too often to the floor to give report. I say, okay then, ma'am, I will stop calling. Then she said that, yeah, and then the lab gave, the lab reported you as well. Let me say, honestly, I don't understand. I'm talking to the manager from a long time regarding this lab thing, because I don't feel as though it's our responsibility. We're here. You only have 2 nurses over here. You don't have a transport. You don't have a tech. You don't have a housekeeper. And when EKG and everything comes in, it's us having to do everything. You understand? We are getting those patients on the LVAD machine. We're doing EKGs, IV. If we need to get them over to CT scan, we have to send them over there. And when the ambulance come, we have to still. So it was just so much. So I don't really understand how is it that you're so, you're arguing about these, because that's what it sounds like right about now. You're talking about these things that you guys need to fix so your staff can be working a little bit safer. The patients can be a little bit safer, because all of what you're talking about, these are things that are not priority right now. The priority is trying to get the med-surg and the PCU to take patients at 4 o'clock in the evening. But I can't tell you that, oh, we're not taking any more patients until 7 o'clock. I never hear about that in my entire life. Like, who gets 3 hours, like, to just sit down on a floor? Like, I am running around in the emergency room and I cannot even get a break, because you say that we don't get no break. We have to sit down and eat while we're working. You understand? And you complaining now that, oh, we call too often to the floor. I'm supposed to call because my patients need to go to the floor. They're not supposed to be here for the last, the next 4 hours, because the nurse is on the floor doing an admission, doing a discharge, on lunch for 4 hours or 3 hours. That don't make no sense. So you need to talk with the managers out there. So anyways, let's say anything else, because this is kind of just getting me upset right about now. It's getting me upset right now. So she said that, oh, and there's another one. So me start laugh. So me say, what else? What else is there? So, so she said that there's another one. So she picked up a piece of paper, print out a letter, and she said that, yes, we got this one the other day from someone. So I'm read it and I say, okay. I say, why did she even write this? I say, why did she even write this? That's the director now. It's not the director. What we call her again? I don't remember what they call it. It's a little bit higher than the director. So I say, I don't even know why she even write that. I say, I don't even. So she wrote that, oh, there was a patient. I started reading it and I was like, yeah, I know the story already. But while I was reading it, the lady said she don't like me. She don't like me. Yeah, I don't like Stacy. Oh, let me see if we can find me later. She said she don't like me. Me not have no conversation apart from where is X and where can I find a chair, some chairs to put in that room. And I pointed. So she put in the email, in the letter, that she asked me for some chairs, and I pointed to room 4. I pointed to room 4 to say that that was the only chair that was available. I guess she thought that I was supposed to go and pick it up, but me never really see it fitting to pick up the one chair in that patient's room and take it and put it in another patient's room that already has a chair. You understand? Because we never had any more chairs in the department. So when the other patient eventually came back, that patient relative was standing in the room because we took up the one chair from that room and put it in the other room. So anyways, she said that, she said she don't like me. How many letter day? Because I was gonna put a, I think I have it somewhere in my thing here. But when she write it, me say, Lord have mercy, why this lady never asked somebody else write the letter, dear Father? Oh, some letter here. I bet it if it was a contact room, she wouldn't exactly. They don't like competent knowledge and hard work if I does. Exactly. So she writes, say, so the lady gave me the, my manager gave me my thing there. So she said, I apologize for the delay in sending you this information. So she sent it to, we have 3 managers. There was one manager that was a traveling manager at the time. And she was in the department, but her personality is like mine. And how I was explaining some of the things to her. And I was saying these things I don't really understand. And that's how she was bringing it up to the other lady, the other manager, because I was telling her that a lot of the things that we're responsible for in the emergency room, I never like it, because when we have patients that we're doing, like, you're prepping for cath lab, you have the LVAD patients dealing with, and the lab is going to call it to tell you that, oh, there's a patient with syphilis that, you need to give the result. You need to call the patient and give the result. So it was our responsibility to call the patients and tell them that you were positive for this, and then the doctor is going to be ordering that. So I was like, this is not like, you guys need to have a different department outside of the emergency room to handle lab results for outpatient. Because this don't have anything to do with us. You understand? So she was working on that. Working on that because she said, no, I'm not supposed to do this. You guys already don't have any staff. Plus, it's only 2 persons. It's a specialist hospital. Somebody else needs to deal with this. So she was talking with them. But apparently, you know, the original manager wasn't doing anything to try and fix the problem. So she went ahead and did, like if the patients were admitted to the hospital, our hospital, then call us with those lab results. If the patient was admitted to the other hospital, you call them and give them the result. You know, call over hospital A, over hospital B to give hospital A result when you have hospital A up and running. So she did that, and that kind of decompressed a little bit. So the calls weren't that bad. You know, the calls weren't that bad. So we went ahead and we were working on that. So anyways, the day when I was doing my evaluation now, what was I saying? Oh, back to this now. So the day when she said that she have another report, because remember, so she go through all of the reports. I say, yeah, those, you need to figure those out because those are kind of too much for us as nurses over here. So she went and she pulled up this thing and give me. So I was there sitting down laughing. Probably she think me a mad woman. But I sit down there and I put on one piece of laughing and see, because when I said this is just weird, I was there reading the letter. Let me read it for you. I apologize for my delay in sending you this letter. On February 6th, my EA relayed a message from a physician whose mother-in-law, hello, VIP. Remember, tell us everybody a VIP for me, you know. Everybody's VIP for me. A physician's mother-in-law was currently in our emergency room. I returned his call and he shared his frustration regarding his family's experience at the hospital. He was very clear that the clinical care received was excellent. The care was excellent. That's how, let me tell you, I feel so good because like the lady, the original lady, because I was updating her and everything, she even offered to buy us food. And I said, no, I really didn't want anything from, because at the time I'm tired, I have my food, and that was just it. I was just doing my duty as a nurse. I never want anything from anybody. Clear that the clinical care was excellent, but that the attitude of the nurse was hostile, in a quotation mark, unfeeling and uninformative, and the family felt like they were imposing on the nurse. After our conversation, I went to the ED to visit the patient. So that part was prior to coming down to the emergency room and talk with the family members. Remember, tell us, so when she come down there, I guess she already had that kind of information in her head because it's a competition hospital. The relative work at, the husband work at, the one that call and load us up. Yes, it was a competition hospital, and he was so upset that we never had any beds. How is it that you guys accepting patients and you don't have no beds, blah blah blah, and the whole 9 yards? And I'm like, I'm not the one that is doing that. I'm just the nurse. You understand? So anyways, that was before coming into the emergency room. So when she come down to the emergency room, I guess she already have her plan. So she went ahead and went in the room and spoke with the patient. As I said, when she come out of the room is small. So I guess with explaining everything and the 5 or 6 relatives in there now with the patient, you know, she gets so sweaty and she come out looking like, she come out looking very sweaty.
When you're done with that, can you kiss me?
Yes, I'll come. So she come out very, very sweaty, and, you know, she wanted the chair, and I pointed her to the direction of the chair. Then she says, no, when I arrived, there were 4 people seated in the nurses' station. As we said, there was me, another nurse, the 2 senior nurses. There was 1 nurse on orientation and the doctor. So there were 4 persons seated in the nurses' station, 3 nurses and the physician. Stacy, as we say, I was sitting at the front facing all the patients, and the other nurse now was sitting at the little triage area. Stacy was seated in the front closest to the patient's room, which was the room directly across from the nurse's station. I asked Stacy, where is could find Miss, L, and she pointed at the door. I opened the door and introduced myself. At that time, the patient's daughter, spouse, adult granddaughter, daughter were present. They had several questions and concerns, which I addressed. Not me, but she wrote the letter. Most were related to her transport. Remember me tell you, say, this patient was initially supposed to go to ICU, but when they denied the patient to ICU because we don't have no bed in the hospital for a couple of weeks, well, almost 1 whole month, we don't have no bed. We never had any beds in the hospital, so when they wanted, because remember, they wanted the patient to come to that hospital, and this patient was 6 hours away. When they denied the patient to the hospital ICU, whatever they did to change the diagnosis to make it say that, oh, the patient don't really need to go to ICU anymore, they went ahead and did something and changed the diagnosis so the patient can come through the emergency room, because guess what? You can't really turn back the ambulance and you can't do nothing. The patient that come in through the emergency room, outpatient, right? It's not inpatient. So they change the diagnosis to make it seem like the patient is coming through the emergency room as a regular patient with 1 bag of medication and this and that. So anyways, she says that the patient had the most were related to her transport. Remember, said the patient was airlifted as well. And then the relatives were driving down the 6-hour drive to come to the facility in the morning. They stated that RN Stacy had told them it may be weeks until she will be assigned an inpatient bed. Remember, tell them, say, we don't have no beds for the last couple of weeks. And this was after I had a conversation with the house supervisor, and we were explaining to them what the situation is, because she don't have any bed to put the patient at. And so what we were going to do is transfer the patient to the other facility that can accept the patient, because there were other patients ahead of her that needed to go to ICU, right? So they also shared that they had asked if there was another chair available for the patient's spouse, and Stacy told them there was only 1 chair per room. 1 chair per room, 5 bed, 5 chair. There was no more. I stepped outside the room and asked Stacy if it is possible to bring a chair into the patient's spouse room. And then she said, not being ED, I honestly wasn't sure if it was a policy. Stacy responded, each room only had 1 chair, and if I wanted another chair, I could find one to bring to the room. You hear the woman lie? Why would I go ahead and tell my big boss that she must go and look for a chair in for her high heels? Why would I tell her to walk in her red bottoms to go and look for a chair? Why would I do that? Anyways, so she said that me tell her that she could go find one. As she going to the patient room to take out the chair. But anyways, Stacy responded, each room only had 1 chair, and if I wanted another chair, I could go find and bring one to the room. There was only 1 other patient in the ED. That's what she said, no, only 1 other patient in the ED. So I went to an empty room and carried the chair to the patient's room. Me say, when I send this to the supervisor, I say, where were the other patients? Where were the other patients? Because it's either we are telling some really huge lies on this floor or something, but where were the other patients? Which room did empty? Anyways, the patient family shared then that Stacy didn't like them. You ever hear anything like that? Me no like them, and hope they would be moved soon. Not that I had a lot of interaction with Stacy, but I will admit to you, I felt the same way. I felt the same way. I'm like, where did I meet this lady again? Big orientation where there was like hundreds of people who working at this facility. Me, a backbench with them on me. You understand? And then this was our second encounter. And anyway, she said she don't like me. I did not verify with Stacy the family's claim that she had told them it may be weeks before she'd be assigned a bed. I only have the family's perspective. See, family's perspective. After leaving the ED, I went to the house supervisor's office and told them, I want that patient moved to the next available bed and PACU could hold. I did not want her down there any longer than necessary. I did feel hostility and friction just being in that space. Again, my apologies for not sending this sooner. Please don't hesitate to reach out with any question. Thank you. So I say, how she feel? I said, Lord have mercy. So she was there, I said to her, I say, you need to ask the nurse and the doctor. The nurses and the doctors that were on the floor, and you need to look at your census in your census up by house supervisor, how many patients were here at the time when this patient was here, and then hear from the house supervisor, mouth, and the other nurses what was happening. This was one of the days when I was the calmest, like, you know, the calmest with everything that was going on. I was like so calm because when I hear that gentleman on the phone initially, I say, you know, I don't really have no time for this right now, you know. I don't have no time for it. And that's why I said to him that if you continue to shout at me, I am going to be hanging up the phone. Him never like it, and so him reload him credentials. And while him there, I said, sir, I'm going to hang up the phone and just hang up. Because I don't have any time for that. I don't have any time for the disrespect, and yeah, I don't have time for it. I do not have any time for it. Then when he called back, we just put him on speaker and let him talk and him continue. You understand? The doctor was like, yeah, no, we're not going to do that today. So I said to the house the director, I said to her, yeah, you can talk to the other people over there, because I said this don't make no sense right about now, because I'm going to write a report. I am going to write a report because her account of this information, she didn't even come to anyone at the nurse's station and said anything to anybody. She just go in the room, get her own little perspective, and then the doctor that was on the phone with her, but because everybody is like, you know, rolling with the big dogs, them just feel as though their point is it. That's it. You understand? Whatever happened and whatever they say is it. And then the little nurses, them now must just sit down and just be like, oh yes. So anyway, she said that she's gonna write me up and I'm gonna be disciplined. I say, yeah, she's gonna discipline. She said to me that she's gonna discipline me because with all the reports that were coming in, it was just too much, and so she's gonna have to write up discipline me, especially with this one, the one that is on the paper. I say, oh. But me always a smiling. I am always smiling. Somebody just say me a smile. And I say, okay, cool. So yeah, we're gonna have to do this. So she was telling me that she was gonna send me something that I have to sign off on and blah blah blah. So I went ahead and I said, okay, then no problem. When am I getting my evaluation, you know, paper sign off? And oh yeah, we're gonna send that off. No. So I said, okay, then no problem. She sent it off, me review it. Everything was excellent. Just sign it. You understand? Sign a piece there. And then she said, oh, we're going to send you the one for the discipline. I said, okay, no problem. I'll look at it when I get home. You understand? So when I get home, I just called the other supervisor and I say, yes, we had a nice little conversation today, but things not go, it's not going to work out. It's not going to be working out because this place is like mix up. Like this place, and I sent her the letter. And I went back. I went in for work, but I sent out, so the same day I sent her the letter and I said to her, she's like, who wrote that? And I'm like, yeah, you know, the big boss. And what I did was the same day when I was supposed to sign, she sent me the disciplinary action thing that I needed to do, because it was like an action plan, blah, 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 one long something. So anyways, let's write up my resignation letter and just send it back to them. You understand? Send resignation letter. Send it out to the three of them. So anyways, she called in the same, when I sent her the letter, that's one of the house supervisor, not the house supervisor, the manager, the traveling manager. She called and she said, Stacy, I see your resignation letter. Say, yes, dear. This is not where work out. My evaluation, me sign it off and everybody sign it now. Me good. You understand? I'm not going to tarnish my name and my reputation. None at all. So I sent him a resignation, and she responded that she got it. Remember, she's not the original manager. She's a traveling manager. So she responded. And then the other two managers that, we always say, they love kiss up to people. The way they, yes, they don't really ask the questions and where you need them. They need to be asking. They don't really ask them questions there. Did you sign? I signed my evaluation. So my evaluation, it never made mention of anything like those. So I signed my evaluation, but then there was another thing for the disciplinary action. So I'm saying, oh, what? We not even look upon that. I didn't even look at it. I just send off my resignation back to them. You understand? And let them know. So up until this day, the other two managers didn't even respond to my resignation. No respond to it. So anyways, while I was there now, remember the schedule, they do the schedule like every 6 weeks. So you have to put in your days for your off days. And based on the time period, remember, so this wasn't planned or anything, my schedule was already made for whatever, but I had plans at the time. And when I sent in my resignation, like I went in the day for work and I went now and print off all of my report them. All of my logs them, just go ahead and just print it out. Print it out nice and neatly, I have them in my paper folder now. And then I had generated a report for them to look into the case itself. Because at the time, before the shift had ended, I had made reference to the whole thing. Like, it was unsafe. It was unsafe. The relative who called was disrespectful. Us giving the information, and then it seemed like everybody on the ship were liars. You understand? So I said that we need to talk about this situation. So I did a report on whatever the day of the incident, because there are certain situations that happen at work. I will write my report because that is what I'm going to have to back me up. Like a couple months later on. And I always finish my shift and do that. If there were too many patients on the floor and my ratio is supposed to be 1-4, may I write a report. Because if something happened, you're not supposed to be on my watch. You understand me? You already know that it's only 2 nurses. You can't have 2 nurses in a cardiac hospital and there's nobody else to do support staff. There's no support staff or anything. And then you're expecting everything to be done. Like if somebody dead, it's going to be on our watch, it's going to be on our watch. So I always start off the shift by, not start off the shift. I always let them know. Them know that 2 person them assigned over there, May I call and say, hey, are we getting any nurse? No. It's okay then, no problem. What's your name? I'll put it on per charge nurse, no additional staff. And that's it. That is what is covering me. So whenever we have high acuity patients and there's just too much and we can't really handle ourselves, yeah, man, may I call again. Any more staff? Do we get any staff? No, we don't have any staff. Yeah, man, because that's how you take responsibility for everything that is going on the floor. And when it comes on to accountability, yes, that's just it. So I went ahead and I didn't sign that form. I sent in my resignation letter and went in for work, print out the forms or the reports that I had made. Like every report we make, I print it out and say, you know what, let me just keep hold these and then from there. So I wrote the report. When I wrote the report and send it off, the census are exactly always high. I sent off the resignation letter and I sent off that letter. So the person who I sent the letter to, remember this, for example, the person may report on named Stacy. I sent the report to John because John is the person that is supposed to be doing whatever. I don't know if it's a case where John see the report and say, Stacy them a report, the boss. So John send it over to Stacy now, and what Stacy do is close the report. So I say, usually they're not supposed to follow back with the report. How is it that the case closed? So because Stacy know that she mixed up and corrupt, she didn't bother even to try to follow up on the case. So anyways, I call the house supervisor when I go back to work and I say, look, the case that we had the day before yesterday, I did a report, but Stacy closed the case. He said, but I know Stacy's supposed to review the case. So anyway, she said, go ahead and send it to this person, the folks above Stacy, so Stacy don't get access to it to close the case again. And so anyways, I went ahead and write the letter and send it off. But at the time, I did also reach out to HR. I was trying to reach out to HR because I never really like how they handle the whole thing, because out of everybody, you just feel like, say, I'm me the problem. So I just wanted to have a conversation with HR as well. Anyways, HR never reached out to me. And when I sent him a resignation letter, and you know, you give them what, 2 weeks notice. So I worked my week, and then how it was set up, I would be off for the next, like, say, 4 days. So in the time period when I'm off, just before the end of my resignation period, I got a call from, I see the hospital name pop up on my phone. I said, hey. So anyways, I answer the call. Oh, Stacy? I say, yes. We got a call to say that you've been missing work. They get a call that I've been missing work. I said, missing work? I said, no, I haven't missed any work since I've been here. Yeah, we get a call from your manager to say that you haven't been showing up for work. I said, oh, that's weird. What days? And she went ahead and she said, oh, you were supposed to be at work, whatever. Like she said, you're supposed to be at work yesterday and the day before. I said, no, I'm not supposed to be at work. It's almost the end of my resignation period. Did they tell you that I resigned and they haven't responded? And I am actually scheduled for off days for the next 4 days. So I really understand why they're saying that. And she's like, oh, you say you're supposed to be off. You're saying that you haven't missed any work, Dave? I'm saying, no, I haven't missed any work since I've been here. This is like one of the easiest departments, except whenever it is like, you know, hospital, except when it is like super busy. So why would I be missing work? I missed the work. So she said, that's weird. I say, yeah, just call up my boss and find out. Call up my manager and find out, you know, what days. Let me see what days they miss. All right, and I'll follow up with you. I said, but did you get my email? Because I did send an email out. I wanted to talk with you guys in HR. Oh, no, we didn't get any email. I said, okay, then cool, no problem, no problem. Yeah, you can call me back after you get an update from my manager regarding the days that I've been missing. And then from there. So anyways, I go on my schedule. I'm a screenshot it, but I always screenshot my schedule, because you know sometimes people go ahead and change things later on. Yeah, man, I love screenshot them. So I screenshot it, and that's what I work with, because I don't want anybody to mess up my schedule and say, hey, you didn't show up for it this day. No, you posted it this day unless you say something to me that you change it, then. But otherwise, when you post it, that is the final thing. So I always go ahead and screenshot or download it, so that way we can have it for my reference and make sure it's a capture. Well, the date is already going to be captured in the screenshot. So that way you can say, oh, but it was posted on this date and this is the day that I was scheduled to work. So anyways, I continue on my merry way doing my own little thing. I tried calling her back. She never answered the phone. I said, okay, then. She don't answer the phone. I sent her a text message. She don't answer the phone. She don't answer the message. I said, all right, then, you know what? I'm going to send an email. Because remember, so even though I'm still in that period, I still have access to my portal and everything. So I said, you know what? Let me just send a nice little email. So I went ahead and it's the same report that I had the file, and she closed it. And I send it back to the other person. I was waiting for them to reach out, but they never reach out. So anyways, we just go ahead and put some package up, you know, print them out and do a few copies of them and send out hard copy. You know, when them fire people real hard, because that's what they did one nurse, you know, they fired the nurse while the nurse is on vacation. So I went ahead and I print out my little thick pages. It was about 16 pages in each package with all of the report. I print them out. Put them in a nice look and say, oh, this one is for the CNO. This one is for the director of nursing. This, like, everybody, down to all the financial advisor get one. And I mail it out. And then I sent an email with the same 15 pages attached. And I send it out to everybody. Send it out. I say, yeah, man. Just like, you see that lady, yeah? She's so corrupt. Somebody out of everybody, at least one person probably read it. I don't know if anybody read it, but all I know, nobody reach out back to me. I didn't hear a word. I didn't hear a word from anybody to say, okay, then yes, we got your letter. We got your letter and your email. Except one person. Oh, the HR before the HR director. Before the HR director, there was one director that was like, let's say they're in charge of the emergency room. Yes, there was one that was in charge of the emergency room. So I did send it to that one first. But she never responded. She never responded until when me send it out as a blast email now. I just send it as a blast email to the most important folks. So they can know exactly what is going on, because there's something must be done about it. And you cannot accept patient and then know when things don't go the way it's supposed to go, you're gonna let me know. Seem like I'm here the problem. Like, I'm not the problem. I'm not the problem. And plus, I never even come and say anything to anybody. You understand? So anyways, I just send out the letter, send out the email. And at the time when I sent it out, she's gonna call now and she's like, Stacy? I'm like, yes. She's like, why did you send out the letter to everyone? I said, because I sent it to you about a week ago and you never respond. You never respond. So it's only because I send it out to everybody know why you call. Well, you should have just sent it to us and that's it. I say, yeah, I send it out to you from long time from you see the length of the email and you see the attachments. You probably should have just reached out and say email received. But not even look at me and say anything. So I don't want to really call me now and I say, I shouldn't send it to everybody because it will show up the ways of these folks. I say, I understand that you guys are, you know, protecting the brand and not protect the face of the hospital. But at the end of the day, who is protecting me? You understand? It can't be a case where she come into the department and she just get the perspective of the doctor on the phone and she go into the room and then she decide that, oh, this is what, and then you're going to tell me that you don't like me. You're going to write a letter and say you don't like me. I don't like you. I don't like you, no. I don't like you either. Because you don't like me, you don't know me, don't like you either. You understand? So I say, it is what it is. You guys can address it later on. I'm open to come into the HR department and have a conversation with you guys regarding it. But I just think it's unfair. And plus, I sent off a report. And she went ahead and reviewed the report and closed it. She closed a report that was done on her. You understand? She closed the report that was done on her. And then just make it seem like it was nothing. I'm like, no. So I take it one step further and just send it out to everybody. But I sent it to you first. I thought you would have called me into the office so we can have a conversation. But it seemed like because you read it through now and you realize that there are so many other persons that are copied to it when they get upset. It's like, I don't really want you to call me again about it. Call me whenever you want me to come into HR and we can have a conversation. All know, you know, all know they don't even say to me that, oh, Stacey, we received your resignation letter. Don't even say them receive it. So I'm like, okay, then you know what? It is what it is. That sounds like, no, this is not Jamaica. This is not Jamaica. This is in the US here. So I just, you know, print out my little things and thing there. But none of them reach out to me. None of the two managers reach out to me. And then what happened is, because they never seemed like they liked the other manager, I think they let her go while she was on like some off days. They tell her that, yeah, not really said let her go, but they told her that they will finish up the assignment. And then they went ahead. There was this other young lady that they went ahead and fired on her vacation. And then it's like everybody just start leaving because they're just too much. It's just too much. I guess they like when persons are, you know, when somebody say jump and you just ask so high, you just jump. Yes, that's the kind of facility it is. And it's one of those facilities I would never recommend anybody like to go there because your license is like at risk, especially if you're a new grad, a new nurse. I wouldn't recommend anybody to go there. Never. That's how it always goes. But God knows best and he always has a bigger plan.
Mommy.
Exactly. It is. I did decide that I wasn't going to work with them, you know, but let me tell you why I decided to work with them. Because I wanted the cardiac experience. Because I did a contract with them at one point. Not that facility there, but the system. I work with another facility under their system. And when I was working there, I was telling some folks on the live the other day, I was working there and I was on like the 99 shift. I was doing the mid shift. And at the time, you know, sometimes hospitals will say that, oh, they have 1 minute wait time. But when you go there, you probably don't even have a nurse assigned to you because they just want the board to look like, you know, that board that you have outside that they're announcing to say that, oh, the wait time is 1 minute. But when you come over there and you think it's 1 minute wait time, it's probably all 2 hours, 3 hours before you get through. because they just don't have anybody in the waiting area, because they put patients in the room that they don't have a nurse for, just to make the waiting area look like, oh, the wait time is like 0 minutes. So I went in for work the day, and when I went in for work, it was, you know, you're gonna get 4 rooms, and they have this thing where they want, just because I want the emergency room to be like, you know, empty, they have this thing like the direct bed. So they take the patients and bring the patients to the room, and then the triage at the bedside. Nothing is wrong with that.
They're taking forever.
I'm coming. Yeah, nothing is wrong with doing bedside triage. We don't have a problem with that. You understand? But when you get in for your shift, it's hard for you to be doing 4 triage at once. And sometimes I feel as though, and then when you say some things to some persons, them take offense to it. But I feel as though some persons who are like placed in triage, they're not thinking about the fact that, oh, it's one nurse, and you know I put 4 patients in a room. 1, 2, 3, 4. You're not getting no vital signs. You barely listen to what the patient have to say, just because you know that the hospital is in the habit of, oh, direct bedding, or, you know, they want the wait time to be down. So sitting triage, looking lost and hopeless, exactly. So they have this thing where they take the patients to the room, and then now you're coming in, and then you're supposed to be doing the triage at the bedside. As I said, nothing is wrong with that. But the nurses in triage still needs to know what exactly is going on with the patient. You still need to triage. You can't just pick up 4 patients and say, 1, 2, 3, 4, come. 1, 2, 3, 4, go in there and lie down until your nurse come. Like, it can't work like that. So when I went and I saw my patients, the first patient I went in and saw, that patient, because the complaints on the board, you know, really reflect much. I don't think that sometimes we are putting the right things on the board with the right acuity. So you can just eyeball a triage board and know, say, okay, then that patient, they write this are dead. Let me go and see that one first. Is that they just put some things and it just there, and then it's you know to try and figure out, okay, then out of everybody that is on the board, even though you probably see a priority 2 and you see a priority 3, the priority 3 needs to be seen based on what the complaint, you know, is. So that was the situation. I went in a room, and this gentleman was just so clammy, was so sweaty. But then the other problem is he was holding onto his chest, and there was a big language barrier. I couldn't leave that patient anymore. That was my priority patient. So even though I show up at 9 o'clock, that was my priority patient. So I was there, and you know, I pressed the call button so they could actually come down, because I don't know what is happening with this gentleman. He had a piece of paper that was in Spanish. I can't read Spanish. Can't read Spanish. Plus, when we take the paper, the gentleman is there, bawling, sweaty. Get the patient on the pulse oximeter on. Couldn't get a pulse ox. You understand? Then I was there, so persons came in the room. Now they're trying to get the EKG. EKG can't go on because the man is so clammy. So I was there trying to get an IV, and it turned out that, let me tell you, it says a drop of blood, literally a drop of blood. But it was a good thing we could do point of care troponin, and that little point of care troponin was what I was able to use and, you know, get the troponin. I've never seen troponin numbers so high yet. It was like in the 90s, the like 90,000 or something like that. I'm like, well. So anyways, we were there now trying to get IVs. We're trying to get the patient on the cardiac monitor, because this patient needs to go over to the cath lab. Let me tell you, say, we didn't even know anything much about the patient. We only know that troponin come back and it's very, very high. You understand? It come back and it's very, very high, and we needed to get this patient to the cath lab. So anyways, we were there. It took us a while before we could get an IV. When we went over with the patient to cath lab, the patient coded. So me over there, the CPR and everything. Poor me never know, said there was another patient in a room that was a stroke patient. So anyways, and I was done over that side, you know, say the patient ended up dying. The patient died in the cath lab. And, you know, you have to do your little notes and all of those things. Everything was happening so fast. We had to do the notes and everything. So anyways, yes, RRT in the ER. So we ended up taking the patient over. Medication system. Okay. I ended up doing the documentation and everything. So after I was finished now, I decided to go into one of the rooms that I was looking on the board. And I was like, okay, then let me go and see this patient because of what was going on. That patient was a stroke patient sitting in the room. It was a stroke patient in the room. So I ended up activating for code stroke. So remember saying, no, this is like a couple hours later on, because the first patient I had was a hot mess, ended up in, cath lab resuscitating, and it was just a hot mess. Then we come back now and hear that, look at the patient, and then based on what is happening, I have to activate a code stroke. So anyways, go ahead, activate the code stroke, do up my notes and everything, only to hear that, oh, you're gonna have to put your time to be this. So I don't understand what you mean by the time, because my triage time, the patient wasn't triage. The patient them lie down in the bed, waiting for their really nice nurse to come and look for them. So anyways, I went in. My encounter was the time that I went into the room. So I got a call to say that, from the manager to say that, oh, this is a stroke center and it don't look good. You need to adjust your time. I said, what do you mean by adjust my time? I don't adjust my time because I cannot give an account for what was happening before. You understand? You need to, I keep on saying, you can't have the triage nurses just putting patients in rooms that are not triage. There's no time, nothing at all, no blood pressure, nothing at all. I'm just to say, oh, direct bed the patients. But you don't need to use no common sense. You understand? So anyways, I said that I'm not doing it. I'm not back timing anything, because when I back time it so your numbers can look good. What happened to my license? You hear that, oh, competent as a nurse, and you have stroke certification, and how is it that you identify the patient having stroke 2 hours later? Like, nobody not tell me no idiot. Yeah. So anyways, they were there and they were making a big deal about it because they were worried about their, their stroke certification and all of those things. And I'm like, I know my problem that. It's not my problem. It's not my problem. My problem is my license right now. You understand? So this is the time that whatever happened, and this is the time that EKG was done. This is the time that we activated code stroke, and everything is based off of that time that I walk into the room. I can't give an account for things that was done before. So even though the patient came 2 hours ago, we already put the patient, so whoever put the patient in the room should have documented, done a triage, and make sure that, the right steps were done to get in this patient activated for code stroke. They don't want to take off any form of responsibility. Exactly. So anyways, I did that. And after I realized that, because some persons were going to change like certain times, I say, you guys are putting your license at risk. We're not putting a license at risk, because, and then it was like a lot of new nurses. So because the managers them say, yeah man, change the time, because you can't have a patient here for whatever time they work. And I'm like, you guys not supposed to do that. So what if something happen? You understand? What if something happen and them come back and say, okay, then this is what happened at whatever time. How are you going to give an account for that? That don't make no sense. It don't make no sense. So anyways, it was like one piece of something, me go ahead and still write my report, because I take my pictures. Yeah, take my pictures and print them out. Because I have to keep a little folder every hospital me going up. Yeah, man, print them out and have them close by, because anything we're too shaky, you understand, me not deal with it. If you look too shaky, I'm not doing it. So I went ahead and printed it out and all. And it was at that time I was like, you know what? I ain't doing this again. Me not come back to the hospital and come work. I'm not coming back. But then I was on a contract and I was doing traveling at the time. And I called this facility. And there was a nurse that I was working with when I just moved here. And she's like, what are you doing at that place? And I said, well, I'm doing traveling still. And she said, why not come to this hospital? And I said, what kind of hospital is that? And she's like, oh, it's a 5-bed hospital. Blah, blah, blah. It's nice, and the only problem is only 2 nurses. And I'm like, okay then. But I know I could do it. So that's why I ended up going to that facility. But in my mind, I was saying, no, Stacey, don't go back to that facility, because they already don't tell myself that I ain't going back to that system for love nor money. But then sometimes, money sometimes dry you out. And that is what they were using at the time. Money, because I did end up taking not taking a contract. I did extend my contract a couple more weeks, because at the time they were paying like, but if you know where you stand with certain things, if you know where you stand with certain things, then you can take a little, but I never spent that long there. And then I went to, do traveling again. And after that, it was you know, I was calling to give a report and somebody was like, oh, hey, Stacy. And I'm like, oh, you're working at that hospital. And that's how I ended up going there because she was there. And I know she was a strong nurse. So I decided to go there and we were working on the shift. And then she left and then I was still there. And I was like, you know, I should have probably come back to this hospital. And then lo and behold, so the same foolishness here again with the facility and the directors and everything. And I'm like, hell no, I would never go back there. Never go back there. Initially I said I was going to write them up first, you know, I was going to write them up because I just think it was unfair in terms of how they went about with dealing with the whole thing. And I'm like, you know what, sometimes you can just call it a day because these are the same kind of folks that will come back and haunt you later on. So we just say, you know what, let me just let it be. Let it be. And just done away with him. But me, I would never go back to one of that facility to work. I would never. And when I talk to people, not on, you know, on here, but I will tell them like, no, don't go to that facility. Stay away from it. They will pay you money, but when they pay you money, you have to take so much risk because especially at the major hospital, like a lot of nurses were over there, they were paying a lot of money, and it was more of, it's all about the time. It's all about the time. And it's like them drill the nurses them to just be looking at the time. And so you find out that the nurses weren't charting anything. The only thing they want to know is that the patient triage and the patient discharge. So you have a triage time and a discharge time. Whatever happens in between, you cannot even tell because the nurses then will tell you that, oh, it's so busy, we don't have any staff. I mean, I always laugh and I say, but look pound too. Look at you guys, but you don't have no staff like you own the hospital. That is not your responsibility. Find the time to make your notes. Find the time to make the notes because under you in charge of the hospital, under your facility, you're in charge of 4 patients. Because at the end of the day, if something happens and you're supposed to go to court or you go to nursing council, what are they going to be like? Oh, well, the hospital had your back? No, they're not going to say that. You think the hospital going to say they had your back? No. I'm going to find out how many patients were you in charge of. The ratio of 4. So find the time to make a documentation. But the nurses, them, sometimes the patients are on some critical medication and nothing at all. The only thing you see in there is a triage notes. And when the medication scan, the titrate and you don't even know where the titrate. The patient have them lines, nothing to chart up. And I'm like, this doesn't make any sense. So they are, you know, and that's the thing, because they always have a lot of opening because the turnover rate is so high. A lot of new graduates find themselves in that kind of situation, and then before you know it, a problem them get themselves in. So anytime you see companies, for me, what I notice is anytime you see companies that have a lot of what they call it, sign-on bonus, because when I was moving to the state here, to Texas, yeah, when I was moving to the state here, I was like, I saw the sign-on bonus, and I say, I who have time for you to give out so much money, and why would I tie myself in a contract for so much money? Because at the time the contract was, I think the sign-on bonus was probably like say $15,000 or $20,000. I mean, I said that don't make no sense. I mean, I try read through it and I say, huh, why would a company be doing this? Let me tell you the amount of sign-on bonuses that they have. I'm like, no, I can't do that one here. I couldn't do it. And so I ended up doing the one with a sign-on bonus that was $1,500. I did one for $1,500. That one was fine. But then I'll come here and I hear about the stories. I mean, I say, oh, no, me see why I not have. Because the turnover rate is like so high. When people realize what is going on, they're leaving. But the thing is, because they're leaving so fast, you have new grads who are not aware of anything that is going on. And so what happens is that them end up and apply for the job and them get position. And then they get into this thing where they're not documenting, they're not doing anything, then just at work. You understand? Work for the money because the boss say, yeah man, jump over there so I get that patient and move over there. And you have 2 minutes to do it. But they don't remember to document anything. And that is a problem that a lot of the nurses were getting into. They weren't documenting and find themselves in issues later on. But, you know, to each his own. That's why I say make sure you document like you're writing a story, a love letter. All right. It's, oh my word, it's so late.
You're coming.
I'm coming. Okay, but anyways, It was a long chit chat. My son is like wanting to go to bed and he want him kiss and he want him stories. So I'm gonna have to go, guys. All right, but thank you guys for hanging out with me. The Jamaican, I can't make them take you off the show. Exactly, Samantha. No, sir. I'm gonna play around with them stuff there. I went through nursing school. I mean, I tell you, say I never had it. I never had it. I mean, I tell you, say I sweat. I work real hard. I work through my entire 4 years. But I spent 5 years in college because I started out with teacher education. But every single day I was working while doing my program. Do you understand? Except when I went to Kingston and then I would come down on Fridays and still be working because I needed the money. So I'm supposed to be like this risky with my license? No, son, nothing love nor money. I work too hard for it. Too hard. So, and like when I have situations like these, I stay very far from it. I document and I print out because at the end of the day, that is what is going to save me. That is what is going to save me. All right, GMAC, thank you so much for tuning in along with the other 22 persons on the live here. I really appreciate you guys stopping by. All right, so I am going to be MR. Yes, so shady, protect yourself. Exactly. So your tutor for NCLEX? Not really, you know. I was doing some study sessions the other day, just general information for nurses, and it helps with NCLEX as well. But I see persons come back and say that a lot of things that I discussed came on the NCLEX, but I don't really tutor for NCLEX. It was just like just coming on the live and just asking questions, answering them. So hopefully I'll get a chance to start that back up hopefully soon, but not right now. All right, Derek. But you can go onto my YouTube page because my YouTube page has a lot of question and answers that we did like last year. Some of them, it's like 4 hours, 3 hours, 2 hours. So there's a lot of information over there that the folks benefited from. So you can go over there and look at it. It's in a folder called NCLEX questions. So we did EKG, GI, cardiovascular, musculoskeletal, neuro questions, like a ton of them. All right. Well, guys, it was nice chit-chatting with you. Thank you for the likes. And if you haven't followed us yet, getting ready to retake it, second attempt, first test, kill me. I'm sorry to hear. But don't give up. Just find one resource that is good for studying, like a review course. And I would say if you can go with UWorld, just because I kind of saw it before and I used it the other day when we were doing the study session. But you can try the UWorld because they have a lot of information there. And then, you know, just try and understand the rationale behind the answers that you are choosing. Or even if you get it wrong, find out why the answer is the safest. Because basically that's what the questions are looking for. The safety. You're choosing the safety. What's up with you? It's all about safety for the question. So just choose and just find the answer and see why that one is a safety answer for each question. All right. But it was nice chit-chatting with you guys. I will see you in another live. This little man is like wanting to go to his bed. He won't go in bed. I didn't realize it was after 10. So it was nice chit-chatting. All right. Say bye.
Bye.
All right. Words so naturally. Thank you, Samantha. All right. Bye.